Dr. Pooja, so the concluding remarks and vote of thanks Dr. Ruchi Pandey is giving, okay?
I can see that you have made the panelists Deepshika Tyagi, Dr. Anandev Singh, and I am also a panelist.
Yes, ma'am, you are also connected as a panelist. So there are two tabs that you can see in the participants. On the left, it is the panelists. On the right, it is the attendees. All the participants who will be joining from the link that was shared would be reflected under the attendees. And the panelists would be under panelists. They have access to the video, to the microphone. And
okay, yeah. Now what I can see is okay. Now panelists, there are 8 people are my panelists, no?
Yeah.
I can see. Sir is there, Dr. Ruchi Pandey, Deepshika Tyagi, and myself.
Yeah.
Okay, from our college. Okay.
So your team, all the 4 people you requested, they are as panelists. You want some more? So what
no,
I
no, that's
okay.
Yeah, we can make Dr. Nipun Dhalla, but he hasn't joined yet. So once if he joins, because he will be able to see, we are all will be on this, no, we'll be talking something other, but he was the person will not be. I mean, he will be able to see all activity.
So at any point of time, just let us know.
Yeah,
what is the name?
Dr. Nipun Dhalla.
Nipun Danda. Okay, whenever he joins, we'll keep a track. We'll create him as a panelist, right?
Yes. Yeah.
So okay. So we'll there is. I'll just take you briefly through the process. What we follow is there are 2 surveys that we conduct: the pre and the post webinar survey. There is a link that will be posted on the chat box and the QR code. So I'll open that. Once that is done, immediately then I'll hand over the time to you and Dr. Deepshika Tyagi, I believe.
Okay,
right?
what I was thinking is, she will say this, and once she will say that there is a pre-webinar survey, then you can take over. I mean.
Okay, fine. So okay, fine. So the opening and everything, she will take care of it.
Okay. Yeah. That
right?
will be,
okay.
Yeah.
Okay, fine.
Thank you.
Thank you.
Then we can log off.
कर दिया है। स्पीकर बंद
अभी देख,
हाँ दर्द इस पे गिर रहा है, थोड़ा डार्क सीधे होगा,
इसको इसको
मतलब हेड डाउन, हेड डाउन।
हर व्यक्ति के पास एक ही लिवर होता है, 2 किडनीज होती हैं, एक ही हार्ट होता है। सवाल ये उठता है कि इन सब में सबसे ज़्यादा ज़रूरी ऑर्गन कौन सा है। हर व्यक्ति अपने हिसाब से सोचता है। कई लोग कहते हैं दिल ज़्यादा ज़रूरी है, कई कहते हैं किडनी, कई कहते हैं ब्रेन, कई लिवर। सारे ऑर्गन ज़रूरी हैं, पर मेरे को लगता है चूँकि मैं लिवर पे काम करता हूँ और लिवर इंस्टीट्यूट में मरीज़ों की देखभाल करता हूँ, पढ़ाता हूँ, तो मुझे लगता है लिवर ज़्यादा ज़रूरी है। और अगर लिवर ठीक रहे तो बाकी ऑर्गन्स भी ठीक रह सकते हैं, जैसे पैंक्रियाज, हार्ट, सारे ऑर्गन्स को लिवर संभालता है। मेटाबॉलिक फैक्ट्री है और बहुत काम करता है, 24 घंटे काम में लगा रहता है। जो आप खाते हैं उसको प्रोसेस करता है, स्टोर करता है, डिस्ट्रीब्यूट करता है, उसको हजम करने में मदद करता है, आपकी इम्यूनिटी को ठीक करता है। पर लिवर कई बार धीरे धीरे करके ख़राब भी हो जाता है, एज से नहीं होता। कई बार उसमें स्वेलिंग आ जाती है जिसे हम इन्फ्लेमेशन कहते हैं, सोजिश। वो सोजिश कई कारणों से हो सकती है। उसमें कॉमन कारण है, सबसे ज़्यादा कॉमन फैट है, एक्सेस फैट आ जाए लिवर में, या अल्कोहल है, और कई तरह के वायरसेस हैं, हेपेटाइटिस बी और हेपेटाइटिस सी। और भी वायरसेस हैं जो पानी से आ जाते हैं, पर जो ही वायरस का नाम लेते हैं तो ही हम लोगों को डर लगने लग जाता है कि पता नहीं ये वायरस क्या करेगा, क्या करता है, कहाँ से आया, मुझे ही क्यों हुआ। और ऐसे भारत में करीब 6 करोड़ लोग हैं और विश्व में बहुत ज़्यादा है। हेपेटाइटिस बी वाले करीब 250 मिलियन और हेपेटाइटिस सी वाले भी करीब 150 मिलियन। मतलब करीब विश्व में इस समय जिन लोगों को हेपेटाइटिस बी है उनकी संख्या बहुत ज़्यादा है। जो इन्फेक्टेड हैं और जिनमें डिजीज़ हो सकती है वो तो और भी ज़्यादा है। तो लोग सोचते हैं, किसी को पता लगा कि मुझे हेपेटाइटिस बी है तो कहते हैं मेरे पास कहाँ से वायरस आ गया, क्यों आ गया, मुझे ही क्यों हुआ। तो मैं आज चाहता हूँ कि थोड़ी सी जानकारी आप लोगों को दूँ जिससे आपका भय निकल जाए, जिससे आप लोगों को लगे कि आप गलत नहीं हो, समाज आपको गलत नहीं समझे और आप अपनी बीमारी, अपने इन्फेक्शन को समझ के और तैयार हो जाएं। हेपेटाइटिस बी जैसे अल्फ़ाबेट है ना, ये 5 उंगलियां हैं। अगर अपन सोचेंगे लिवर में कौन कौन से वायरसेस आ सकते हैं तो एक हेपेटाइटिस ए, बी, सी, डी और ई, 5 वायरस लिवर में जा सकते हैं। ए वायरस और ई वायरस, ये दोनों अंगूठा और छोटी उंगली, ये तो भोजन पानी के द्वारा जाते हैं। लेट्स से हेपेटाइटिस ए बच्चों में होता है और एक बार हो गया तो दोबारा नहीं होता। भारत में करीब करीब हर बच्चे को, मुझे भी हुआ था, हर एक को हेपेटाइटिस ए हो सकता है। हो जाए तो फिर लाइफ लॉन्ग बचा रहता है। हेपेटाइटिस ई पानी से, भोजन से, बारिश के मौसम में ज़्यादा जब सीवेज का पानी, खराब पानी पीने के पानी से मिल जाए, या आपने ऐसे फल वल खा लिए हों जिनके अंदर की वायरस आ जाए, तो हेपेटाइटिस ई आता है। अब रहता है सवाल 2 इम्पॉर्टेंट वायरसेस का, बी और सी। डी और बी हमेशा साथ होते हैं, डी अकेला कभी नहीं आता, बी के साथ ही आता। तो 2 ही मेन वायरस रहे, हेपेटाइटिस बी और सी। और जैसा मैंने बताया दोनों साइलेंट है, मतलब पता ही नहीं लगता, चुपचाप रहते। पर अगर हम समझ जाएं तो हम पता लगा लेंगे कि चोर कहाँ छुपा है। पहले देखें वायरस होता क्या है और कैसे आता है। शरीर में बहुत सारे कीटाणु आ जाते हैं, वायरसेस आ जाते हैं, बैक्टीरिया आ जाते हैं, तो हमको हर एक से तो कोई नुकसान नहीं होता। हेपेटाइटिस बी एक वायरस है जो कि ब्लड में जाता है और मैन टू मैन ही ट्रांसफ़र हो सकता है। जैसे मेरे में अगर हेपेटाइटिस बी है तो मेरे से ही दूसरे को जा सकता है, दूसरे में इन्फेक्शन है वो अगर अपना ब्लड देगा तो तीसरे को जा सकता है। तो सबसे कॉमन तरीका वायरस के ट्रांसमिशन का हेपेटाइटिस बी का माँ से बच्चे को। तो जैसे अगर कोई 25 साल का व्यक्ति आया है, वो नौकरी के लिए जा रहा है, सडनली पता लगा ब्लड टेस्ट में, अरे मेरे तो हेपेटाइटिस बी है, उसकी तो जान निकल जाती है। वो सोचता है मेरे साथ ऐसा क्यों हो गया, मैंने क्या गलती की। उसके पास पड़ोस वाले सोचते हैं इसने कोई ज़रूर गड़बड़ किया होगा तभी इसको हेपेटाइटिस बी आया है, क्योंकि बहुत समय से हेपेटाइटिस बी को HIV के साथ जोड़ दिया जाता है कि हाँ HIV है, वो सेक्सुअली ट्रांसमिट होता है, तो हेपेटाइटिस बी। हाँ, हेपेटाइटिस बी भी सेक्सुअली ट्रांसमिट होता है पर बहुत कम, जनरली माँ से बच्चे को आता है। तो जब बच्चा पैदा हुआ पता ही नहीं लगता, क्योंकि माँ से जो चीज़ मिली वो अच्छी लगती है, नाक कान गला सब ठीक है। तो वायरस बी को भी बॉडी अपना समझ लेती है और 25 साल 30 साल 50 साल तक वायरस साइलेंट रहता है, पता ही नहीं लगता। और फिर किसी किसी में लगभग 10% में वायरस से बीमारी हो सकती है। 1% ऑफ द टोटल कैन डाई ऑफ हेपेटाइटिस बी। तो मैं ये आपको बताना चाहता हूँ कि बाकी 90% या बाकी के 99% वो बेचारे डर से ही मर जाते हैं। पर हमें पता कैसे लगे कि हमें हेपेटाइटिस बी है और ये करता क्या है। वायरस लिवर के अंदर जाता है, धीरे धीरे मल्टीप्लाई करता है और मल्टीप्लाई करके लिवर के सेल्स को डैमेज कर सकता है, हर एक में नहीं 10%, और डैमेज करके लिवर सूख जाता है। हम उसे कहते हैं हेपेटाइटिस और फिर कहते हैं सिरोसिस, किसी किसी में कैंसर भी हो जाता है। पर ये सारी चीज़ें हम बचा सकते हैं, सारी चीज़ों को हम ठीक कर सकते हैं। अगर हम देखें जिसके परिवार में किसी को हेपेटाइटिस बी है वो सारे परिवार वाले अपना टेस्ट कराएं और जो पॉजिटिव है वो ट्रीट हो जाए, और जो नहीं है, जिनमें इन्फेक्शन नहीं है, उनको वैक्सीन लगवा दें। तो हेपेटाइटिस बी के लिए ये बहुत आसान है पता लगाना कि वायरस अगर माँ से आया, उसको उसकी माँ से आया, आपकी गलती नहीं। जैसे माँ, आप कोई 25 साल वाला है, उसकी मदर है लेटर से 45 साल की, उसको उसकी मदर से आया, पर 45 साल तक उसको पता ही नहीं लगा लेडी को। तो अब हम क्या करते हैं, इस पूरे प्रोसेस को हेपेटाइटिस बी के 3 भागों में डिवाइड करते हैं। पहले कि वो वायरस कितना है, दूसरा वायरस से सोजिश कितनी है, और तीसरा वायरस से लिवर कितना सूखा। अगर लिवर सूखा है या सोजिश है तो दवाई देंगे, और अगर नहीं है, खाली वायरस है, बीमारी नहीं, तो कोई चिंता ही नहीं। जैसे घर में चोर आ जाए, चोरी नहीं करे, बैठा रहे, तो हमें कोई परेशानी नहीं। तो 90% लोगों में वायरस क्वाइट रहता है, 10% में ज़िंदगी में कभी वायरस एक्टिव हो जाता है। पर इसकी समस्याएं बहुत हैं, शादियां टूट जाती हैं, सगाई टूट जाती है, नौकरी नहीं मिलती। अगर हेपेटाइटिस बी पॉजिटिव है उसको वो लेते ही नहीं। तो हमारा ये जो सोसाइटी है उससे आदमी इतना डर जाता है कि वो बोलता ही नहीं। जैसे चोर हो गया ना, उसको पकड़ के अंदर डालेंगे ही डालेंगे। तो इसी तरह अगर हेपेटाइटिस बी वाला है तो उसको नौकरी नहीं देंगे, उसकी शादी नहीं करने देंगे, बच्चे नहीं करने देंगे, उसके हस्बैंड उसको छोड़ देंगे, या नौकरी से निकाल दिया जाएगा, या कहेगा नौकरी बदलनी पड़ेगी, आप इस तरह की डॉक्टरी नहीं कर सकते, आप सर्जरी नहीं कर सकते। ये सारी चीज़ें डराती हैं व्यक्ति को बोलने से, डराती हैं उसको बाहर निकल के अपने आप के इन्फेक्शन के बारे में बताने में। मैं चाहता हूं कि आप सबको बताऊं कि हेपेटाइटिस बी आसानी से ठीक हो सकती है। अगर पता लगा कि खाली वायरस है, बीमारी नहीं है, तब तो कोई चिंता ही नहीं, वायरस को किसी भी दिन दवाई से दबा सकते हैं। और अगर बीमारी है तो उसका इलाज होगा, तो वायरस धीरे धीरे कम हुआ, बीमारी भी ठीक हो सकती है। बाय द वे कोई कैंसर हो गया, बाय द वे कोई सिरोसिस हो गया, लिवर खराब हो गया, तो बदल देते हैं, लिवर बदल जाता है, ट्रांसप्लांट हो जाता है। तो हमें ये मान के चलना है कि भारत में जो 4.5 करोड़ लोग हैं जिनमें इन्फेक्शन है, वो सब एक दूसरे से बात करें, पता लगाएं कि इसका इलाज है। और भारत सरकार ने तो अब एक प्रोग्राम शुरू कर दिया है जिसके अंदर सबका फ्री डायग्नोसिस, सबका फ्री ट्रीटमेंट हो सकता है। और आप अपने आप को दूसरे से बात करें, डरे नहीं, छुपाएं नहीं कि मुझे है। हम लोग जो ये मुहिम है, जो मिशन है, जिसके लिए कि भारत में किसी को भी अब हेपेटाइटिस बी वाले को परेशानी नहीं। और हाँ, सबसे ज़रूरी बात, अगर कोई बच्चा आज पैदा होता है उसको तो आप 100% बचा सकते हैं। जिसकी माँ को वायरस नहीं है उसको भी टीका लगाना है। जिसकी माँ के वायरस था और बच्चा नया पैदा हो रहा है उसको भी टीका लगाना है और इम्यूनोग्लोबुलिन भी देना है। अगर आपने उसको वायरस का टीका लगाया, हेपेटाइटिस बी का, और इम्यूनोग्लोबुलिन दिया तो बच्चा सुरक्षित है। एबॉर्शन की कोई ज़रूरत नहीं, टर्मिनेशन ऑफ प्रेगनेंसी की कोई ज़रूरत नहीं, हस्बैंड को वाइफ को नहीं छूना, उसके साथ नॉर्मल मैरिटल रिलेशन नहीं रखना, ये सब गलत है। आप नॉर्मली रह सकते हैं। वाइफ से हस्बैंड को बहुत रेयरली ट्रांसमिशन होता है, तो इसलिए ये संभावना कम है। तो हम अपने आप को लेट अस टॉक, लेट अस गेट टेस्टेड, लेट अस गेट ट्रीटेड, और इस तरह से हम अगर करें तो 4.5 करोड़ लोगों को जिन्हें बी है वो धीरे धीरे सोर्स ही ख़त्म हो जाएगा। और हर नया पैदा होने वाला बच्चा, उसको हमने टीका लगा दिया। तो अगर हम ऐसा करें तो 20-25 हो सकता है 50 साल में सारे हेपेटाइटिस बी वाले ख़त्म, भारत हेपेटाइटिस बी से मुक्त हो जाएगा। अब रहा हेपेटाइटिस सी, जो दूसरा वायरस, मैंने 2 बताए थे ना, एक बी और एक सी। सी वायरस भी वैसा ही है, ये ब्लड से आता है। जैसे इंजेक्शन की वही नीडल बार बार लगाई जाए, जैसे मेरे में हेपेटाइटिस सी हो और मेरे को इंजेक्शन दे तो उसके नीडल में भी थोड़ा ब्लड आ जाता है, वो ब्लड में हेपेटाइटिस सी होगा। उसी नीडल से दूसरे को लग गई, उसको भी हेपेटाइटिस सी हो सकता है। तो हेपेटाइटिस सी जनरली नीडल से, ब्लड से, ट्रांसफ्यूजन से एक से दूसरे को जाता है। और सोर्स इसका भी मैन टू मैन ही है, मतलब एनिमल से वायरस आ जाए ऐसा नहीं। तो अगर हमने, जो भारत के अंदर करीब 8 लाख के करीब लोग हैं जिनको हेपेटाइटिस सी है, उन सारे लोगों को, 8 मिलियन के करीब भारत के अंदर हैं, 80 लाख के करीब, उन सारों को अगर हम लोग इलाज कर दें, और इलाज बड़ा आसान है, 3 महीने की दवाई दीजिए, सस्ती दवाइयाँ हैं और वो भी दवाइयाँ फ्री मिलती हैं सरकार से। अगर हमने वो दवाई दे दी और 3 महीने में 95 से 98%, और इतना अच्छा इलाज और है ही नहीं, किसी तरह की एंटीबायोटिक में भी इतना अच्छा इलाज नहीं कि भाई 98% लोग ठीक हो जाएं सिर्फ 3 महीने की दवाई से। तो हम अगर ये सारे लोगों को ट्रीट कर दें तो हेपेटाइटिस सी भारत से ख़त्म हो जाएगा। और ट्रीट कैसे करें वो व्यक्ति बताता ही नहीं है। तो इसका भी बहुत आसान तरीका है। कभी किसी को ब्लड चढ़ा हो, कोई ऑपरेशन हुआ हो, 2001 से पहले, 2001 के बाद सारे ब्लड बैंक टेस्ट कर रहे हैं। अगर कभी टेस्ट हुआ, अगर आपका ऑपरेशन हुआ, गायनी का, प्रोस्टेट का, हार्ट की एंजियोग्राफी हुई या कोई और तरह की सर्जरी हुई, कभी ब्लड चढ़ा हो या नीडल हो, पर कई लोग नीडल को यूज़ भी करते हैं ना, ड्रग यूज़ करते हैं, उन लोगों को भी हेपेटाइटिस सी का टेस्ट कराना है। एक बार टेस्ट कराया और पता लगा कि वायरस है, आपने इलाज करा लिया और आप ठीक हो गए। हाँ, अगर बहुत समय पता लगा और आपने इलाज नहीं कराया तो कई बार लिवर डिजीज़ हो जाती है, सिरोसिस हो सकता है, कई कैंसर भी हो जाता है हेपेटाइटिस सी, पर वो सब भी ट्रीटेबल है। तो दोनों बी और सी बीमारियां अगर आपने पता लगाई, साइलेंस से उनको एक्टिव किया, एक दूसरे से बात की। कई इलाके हैं भारत के अंदर जहाँ बहुत लोगों को हेपेटाइटिस सी है, उत्तराखंड है, यूपी के कई एरियाज़ हैं, कश्मीर के एरियाज़ हैं, जहाँ पे पंजाब है, बहुत सारी पॉकेट्स हैं। मैं चाहूँगा वो सारे लोग, पूरे इलाके को ही आप छान मारें, सब लोग अपने आप टेस्ट कराएं। आप कहोगे मुझे तो कुछ नहीं होता, मैं तो ठीक हूँ। हाँ, आज ठीक है, बट टुमारो virus can create problem for you, it can create difficulty. So both are treatable, both B and C. It is advisable that किसी को अगर वायरस है then we should try and get tested. आपने टेस्ट किया, वायरस पता लगा, इलाज करा लिया और ठीक हो गया। पर उसके साथ एक और बहुत ज़रूरी है, अगर आप ठीक हो गए तो मान के चलिए कि कम से कम 100, चलो 100 नहीं 10 लोगों को और आप बताओगे, आप बता के कहोगे भाई तू भी टेस्ट करा ले। कभी अस्पताल जाए, कोई हेल्थ चेकअप हो, कहीं ब्लड डोनेशन में तो वैसे ही टेस्ट हो जाता है, आप अपना बी और सी का, चलो आप अपने मामा जी को ले गए, चाची को ले गए, कहीं अस्पताल गए, उनके टेस्ट हो रहे, आप भी अपना करा लो। अगर आप अपना टेस्ट करा लोगे और पता लगा कि हाँ भाई मेरा लिवर ठीक है, एक SGPT का टेस्ट करा लो तो पता लग जाएगा लिवर में सोजिश है कि नहीं। हेपेटाइटिस बी और सी का टेस्ट करा लो और एक अल्ट्रासाउंड करा लो। आपने 4 चीज़ें करा ली, सब ठीक है भाई, मेरा लिवर ठीक है। हाँ, अगर ये सब ठीक है तो दूसरे को बताना कि कैसे लिवर ठीक रखना है। बी और सी के टेस्ट हैं और वैक्सीन लगवाएं। वैक्सीन लाइफ में हेपेटाइटिस बी के लिए, सी की कोई वैक्सीन नहीं। तो अगर हमने 3 टीके लगवा लिए हेपेटाइटिस बी के, किसी भी टाइम में लाइफ में लगवाने पड़ेंगे, शुरू में 1 महीने बाद और 6 महीने बाद, तो फिर आप लाइफ लॉन्ग प्रोटेक्टेड रहेंगे। और अपने बच्चों को ज़रूर टीका लगवाएं, जैसे आप पोलियो का लगवाते हैं हेपेटाइटिस बी का भी लगवाएं, और वो बच्चा लाइफ लॉन्ग हेपेटाइटिस बी से बचा रहेगा। बड़ी इफेक्टिव वैक्सीन है। थैंक यू।
With your permission, Dr. Pooja, may we start? I believe we have our participants connected by now.
Yes, madam, we can start.
All right. So a very warm good afternoon and a very warm welcome to the Department of Perinatal Manav Rachna Institute of Research and Sciences. I welcome you all, distinguished panelists, respected speakers, and all the participants who are joining us today for the national webinar on the recent advances of prevention and control of hepatitis B and C. I am Dr. Namrata Mohan. I serve as a project officer with the Empathy Campaign. This is an initiative of the ILBS and the Airport Authority of India. Before we formally begin, and I hand the time over to Dr. Deepshika Tyagi for a formal beginning, I request you all to kindly take a brief survey. Kindly just follow the link that is being posted on your chat box. And also alternatively, you could just scan the QR code that is being displayed on your screens right now. I request all the participants to kindly please follow the link that is being posted in the chat box, or alternatively, you can scan the QR code that is displayed on your screen right now. This will take you to a brief questionnaire, that is the pre-webinar survey. Kindly fill out those questions and make sure that you do submit the survey. At the end of the session, we will also have a post-webinar survey. For the participants who submit both the surveys, you'll be able to generate a link that enables you to download your e-certificates. Once again, in case for you to download your e-certificates, kindly fill out the pre and the post-webinar survey. Right now, we are having the pre-webinar link that is posted in the chat box and also the QR code that is being displayed on the screen. Make sure you do submit both the surveys. The other one would be at the end of the session. That will enable you to download your e-certificates. Just a little housekeeping before we get started. If you have any questions during the presentations, please type them into the question answer box, which you may please locate in your Zoom control panel. Please do not leave the questions or queries in the chat box. All the questions that you post in the Q&A box will be answered by our team. And I also request all the participants and the panelists to kindly put yourself on mute for the time being. Our team will try to address all the questions and the queries that you post in your question and answer box during the sessions. And also we will have time to take the queries towards the end of the session during the plenary session. So while the participants may take some time to submit the pre-webinar survey, I invite Dr. Deepshika Tyagi to formally begin the webinar and the sessions for today. Dr. Deepshika Tyagi, over to you, ma'am.
Thank you so much, ma'am. Good afternoon, everyone. I, Dr. Deepshika Tyagi, from the Department of Periodontology, Manav Rachna Dental College, welcome you all to the national webinar on prevention and control of Periodontology Dental College in collaboration with the Institute of Liver and Biliary Sciences, New Delhi. Viral hepatitis has become a silent epidemic worldwide, and India has intermediate endemicity of hepatitis virus. According to the data provided by WHO in Global Progress Report on Viral Hepatitis in the year 2021, it was reported that approximately 1.5 million people were infected with hepatitis B virus, and about 820,000 deaths were reported due to hepatitis B virus related causes. A pervasive increase in serious transmissible diseases over past decades have created a global concern and affected the treatment approach of all healthcare professionals. There is an increased incidence of hepatitis B virus among dentists, dental staff, and students. And it was noted that the overall awareness among dental students is only fairly satisfying, which signifies there is a need for continued infection control education among the students. Without further ado, I would like to invite Dr. Arundeep Singh, sir, Principal, Manav Rachna Dental College, in order to address the meeting. Over to you, sir.
Thank you, Deepshika. Thank you, the organizers, Dr. Namrata. And it's my exposure to this empathy program is nearly 2 years old when I visited ILBS as part of, I think, one of the seminar being organized, and that's where I got exposed to the empathy team. And we had the people visiting our college for vaccination of our students. So that's when I got to know about this campaign, and it's an excellent campaign. And as all of us know that hepatitis is a major public health problem, and it's, as they say, the 10th leading cause of death worldwide. Like it was just said that probably 6 crore Indians are suffering from some form of hepatitis. And we have the largest global population. Maybe percentage-wise, we might be less, but as in numbers, we have a very large global pool of people suffering from hepatitis. So I think campaigns like this are a dire need to remove all the misconceptions, and like Deepshika was saying, that the knowledge among healthcare professionals also is, I was reading an article which said that dentist has 10% more chance of getting hepatitis, 10 times more chance of getting hepatitis if he or she is not vaccinated. So we still need to get this message across to people and healthcare professionals also, that vaccination is important, and we are able to protect ourselves by getting vaccinated. From another article that I read was, as dentists, we are really prone to hepatitis, especially hepatitis B. When I was an undergraduate student, I remember reading that, we talk about HIV, but it is more, as a dentist, the chances of we getting a hepatitis B is more than getting HIV. So we have to be very careful, and this finally results in can cause liver cancer and so many other problems. And technically, they say specialties of oral surgery, periodontics and endodontics are the ones who are more exposed and more So I think today's webinar is totally called for, and it'll be really informative for my students. So we have a good catchment of people who need this education about hepatitis, how to prevent, and what all. I think I'll also be taking one session on what can we do as dentists to prevent hepatitis in our clinics, in our settings. So all the best to the organizers, Department of Periodontology. Again, they've taken the initiative and made this webinar possible. So congratulations, Dr. Pooja and your team, and ILBS, of course, and Dr. Amrita. Thank you, and all the best for today's webinar. Thank you.
Thank you, sir, for your kind words. Now, I would like to invite Dr. Pooja Palwankar, Dean PG Studies, Professor and Head, Department of Periodontology, Manav Rachna Dental College, to welcome the guest speakers.
Thank you, Dr. Deepshika. I would like to extend a warm welcome to the esteemed speakers on this platform, Dr. Manya Prasad, Assistant Professor, ILBS, Dr. Ajit Singh Badoriya, Associate Professor, AIMS Rishikesh, Dr. Archana Ramalingam, Deputy Director, NIE, ICMR, Chennai, Dr. Ekta Gupta, Professor, ILBS, Professor Dr. Arundeep Singh, Principal MRDC, Dr. Rahul Gehlot, Project Officer, Empathy, ILBS, Dr. S.K. Sareen, Vice Chancellor, ILBS. This webinar is jointly organized by the Department of Periodontology, Manav Rachna Dental College, and Institute of Liver and Biliary Sciences on the topic Prevention and Control of Hepatitis B and C. Our association with ILBS is from year 2019, where one day seminar was organized on viral hepatitis in dentistry in the name of Project Precautions and ECO. We jointly conducted I Pledge My Support program in year 2020, which was followed by screening and vaccination for students, faculty, and healthcare workers. Dentistry is considered to be a high-risk profession for contracting hepatitis. Thus, the objective of this webinar is to sensitize the dental students against the hepatitis B and C through this national webinar on prevention and control of hepatitis B and C. Thank you.
Thank you, ma'am. Moving on to the first speaker. The first speaker for today is Dr. Manya Prasad. She will be discussing the burden of hepatitis B virus and hepatitis C virus in India. Dr. Manya Prasad is currently the Assistant Professor, Clinical Research Epidemiology in Institute of Liver and Biliary Sciences, New Delhi. She has 35 international and national articles in Medline Index journals. Her area of interest is epidemiology, medical research, systematic reviews and meta-analysis, evidence-based medicine. She has facilitated many workshops on research methodology, evidence-based medicine, and grade 2. She was awarded gold medal in MD final exam, and she is a recipient of International Epidemiology Association Fellowship. Over to you, ma'am.
Thank you so much, Dr. Ruchi, and I extend my gratitude to Manav Rachna Dental College and to Arundeep Singh sir for jointly collaborating with us on this very important webinar. And I hope that this very important session goes a long way in strengthening the government's efforts against hepatitis. So without much ado, I will get right down to the video that I've been, the presentation that I've been asked to talk about. So what I'm going to be talking about is the current disease burden of hepatitis B and C in India. And what this will contain is the reported estimates of the prevalence of chronic infection in India. I will do a critical review of the current literature and provide estimates from recent studies. This will be followed by a bit of an academic discussion regarding the limitations of the current literature that report estimates of burden. I will move on to talking about the rate of complications with hepatitis B and C and finish with some steps needed. So needless to say, the liver is a very important organ in the body. It serves a whole array of functions and works day and night. Now, what damages the liver? Well, principally, there are three things. Alcohol, which is the most talked about risk factor for liver damage. Fat, which is very quickly overtaking the rest of the risk factors for liver cirrhosis and cancer. So non-alcoholic fatty liver disease is predicted to become the most common cause of liver-related mortality and morbidity in the future. And then finally, we have viruses, what we're talking about today. So mainly three things out there that can damage the liver. And then there are some rare causes like autoimmune diseases and so on. So Dr. Badoriya will tell you more about types of hepatitis. But there are, as you probably are aware already, 5 types of hepatitis. And out of these, B, C, and D are bloodborne, and A and E are transmitted through contaminated food and water. So why should we worry about hepatitis and why should we focus on this in terms of turning our attention to interventions for hepatitis elimination? Well, because it's one of the leading causes of mortality worldwide, and it's certainly a very important public health problem in Southeast Asia, of which India is a part. It's a communicable disease where mortality is observed to be increasing. So, so out of HIV, tuberculosis, and hepatitis B, it was observed that mortality for the other two was decreasing, but for hepatitis it was actually increasing. And it's responsible for as many, if not more, deaths annually than TB, AIDS, or malaria. 90% of these deaths are due to hepatitis B and C infections. And we need to think about this carefully because this is a communicable disease which is amenable to very easy prevention and control. So we have a very effective vaccine against hepatitis B, and we have a cure for hepatitis C. And so this is actually something we can do a lot about. How has the pandemic affected elimination efforts? Well, they have severely disrupted key interventions that go towards hepatitis elimination. COVID-19 has posed a major challenge in achieving hepatitis elimination because key interventions like screening and vaccination and health education was severely disrupted because of the lockdowns. And it's been documented that hepatitis has suffered among the highest disruption of all diseases, which is more than that for HIV, malaria, and tuberculosis. So it's about time that we turn our attention back to this very important disease. When we talk about the burden of hepatitis B and C, what we're worried about is not just the acute infection. So very often with hepatitis, what we have is a fever, malaise, jaundice for a few weeks and then or days, and then the patient recovers. But with hepatitis B and C, what we're worried about is when the virus lingers on in the liver. So the inflammation continues over many years. And this is chronic hepatitis. So with chronic inflammation, what this results in is scar formation, so fibrosis. And over time, long-standing fibrosis can lead to a very, very serious condition called liver cirrhosis. So this is an irreversible liver damage. And then over time, this can progress to hepatocellular carcinoma, so cancer. So hepatitis B and C we'll see in subsequent slides. Very important cause of these very serious liver-related complications, which is cirrhosis and hepatocellular carcinoma. So coming on to the numbers, the worldwide prevalence, the absolute number of people who are living with chronic hepatitis B is 296 million and 68 million with chronic hepatitis C. And according to the 2015 WHO estimates, viral hepatitis accounted for about 1.4 million deaths worldwide. In 2019, hepatitis B resulted in an estimated 820,000 deaths, and most of these deaths were from liver cirrhosis and hepatocellular carcinoma. So you can see huge burden there in terms of morbidity and mortality. Up to 40% of chronic HBV infections develop serious sequelae during their lifetime. So cirrhosis and hepatocellular carcinoma. And cirrhosis accounts for 720,000 of these deaths, and hepatocellular carcinoma for about 500,000 deaths. So again, you can tell huge numbers there with regard to the worldwide burden. And so this is how the numbers are spread out across the WHO regions. So overall, there's 296 million, and then there's some disparity with regard to how this is distributed amongst the various WHO regions. So some regions are facing the greater brunt. Some, like African and Western Pacific, have a high burden of cases, but also Southeast Asia, so 60 million cases there as well. And for hepatitis C also, 68 million cases worldwide, and then this is the spread of the burden by WHO region. And again, you can see here Southeast Asia region, 10 million cases, so not a small number. Within the Southeast Asia region, if you talk about the prevalence of surface antigen, that's how they measure the burden of chronic hepatitis B, by measuring surface antigen. And you can see here that within the region, there is disparity in the countries as well. So there's a gradient here with regard to how many, what is the prevalence. And some countries are definitely facing a higher burden, like Bangladesh, Indonesia, Myanmar, Thailand, and so on. And I'll talk more about the estimate for India in the future slides. And also for hepatitis C, again, some countries facing a higher burden. And mostly this is because of the rate of transmission of mother to child. So again, Indonesia, Myanmar, Thailand, etc., a very high burden in these countries. So if we talk about the prevalence of chronic hepatitis C in India, the estimate comes from mainly 3 research groups. The first is the paper by Schweitzer et al., which was published in the Lancet. And the second is the WHO estimate, which engaged a number of agencies to arrive at this estimate. And the third is the CDA Polaris group. So you can, what you see in the middle here is the point estimate for the worldwide prevalence and for India. And then in the bracket, this is the 95% confidence interval. So you could, as you probably are aware already, you can think of this as the margin of error. So, so what we have from these estimates is a 1.46% prevalence of chronic hepatitis B. And again, this arises from the prevalence of surface antigen studies that have reported prevalence of surface antigen. And you can see here that the WHO estimate, a little bit of discrepancy, but then a large overlap in the confidence intervals of these 2 estimates as well. So little higher, but there's an overlap. So these are the estimates that we have for India by 3 research groups. If you're wondering how these research groups arrived at the estimates, they've all done systematic reviews and meta-analysis. So as you are probably aware and probably have been engaged in some systematic reviews, they are basically study of studies. So they have systematically looked at what's out there in terms of literature, and these are the databases that they searched, probably avenues that most of you go to as well when you're looking for evidence to a clinical question. And how they differ is a little bit with regard to the included countries. So there's some differences in the kind of in the number of countries that they enjoy in terms of inclusion of studies from those countries. And most of them are excluded high-risk populations. So non-representative and very high-risk populations are excluded. But some of the differences can be explained with regard to what they included in terms of list of countries. So this is purported to be the most reliable estimate so far. This is a paper by Schweitzer et al., which included 129 studies and 3.7 million subjects. The prevalence reported is 1.46%, so just under 2%. And that's an estimated 17 million chronic carriers. If you look at the time trend, so how did, if you compare time periods, so 50s to 80s compared to the next decade or so, you see here that there has been a reduction. So there is a reduction in prevalence of hepatitis B, and what we can attribute this to is probably the vaccination that's been implemented as part of routine universal immunization. So there has been a reduction, and this is also reflected in the WHO estimate. So if you compare the pre-vaccination estimate to the 2019 estimate, you see that there has been a reduction, and Again, this is probably attributed to vaccination. So recent studies, the next 3 slides are the recent studies that have been conducted. And what you'll notice from this is that there's a high level of variation with regard to the kind of population that they've enrolled and the testing method that they have done. So, high level of heterogeneity. So some have enrolled patients, some have enrolled healthcare workers, some have been community-based studies in general population. And these differences can probably explain the discrepancy in the prevalence that is reported from all of these studies. So again, you have differences in testing methods as well. And so, we still desire a very good, robust, nationally representative survey that can tell us very accurately and with a high degree of certainty what the prevalence is, what the national prevalence is. But we do have some idea from these studies and from the reported estimates from previous research groups. If you talk about the prevalence of chronic hepatitis B, again, this was a systematic review that reported a range 0.09 to 15 from this is basically all the studies that they included. But if you take the estimates from just community-based studies in general population, blood donors, and pregnant women, the estimate is 0.85%. And that's basically 6 to 12 million people account for this estimate. And 3 to 9 million persons have active HCV infection. And chronic HCV accounts for up to 30% of HCC and 20% of cirrhosis. Now, you could tell that there are some limitations of the current literature. As you could see from that table, the quality of reporting is highly variable. And there's a combination of robust and non-representative studies that have enrolled different kinds of age groups, have been done at different time points, and there's paucity of data with regard to age-specific estimates and sex-specific estimates. So we don't really have, if you ask me, are there any gender differences that we've seen? We don't have a very high-quality evidence that can detect that signal. Also, evidence on infants and young children is mostly absent. Some of the studies have been done in blood donors, and it's likely that more healthier people are likely to come in for donation, so that could possibly be an underestimate. And the estimates are mostly from subnational. There are some national studies, including one recent one, but they have to be subjected to a good critical appraisal. And some studies have targeted very high endemic areas, so areas like tribal regions, etc. So coming on to the mortality, what this graph displays is the number of deaths that can be attributed to cirrhosis and hepatocellular carcinoma from chronic HBV and HCV. So the very lightly shaded portion are the deaths from hepatocellular carcinoma, and the darkly shaded one is cirrhosis, and the very darkly shaded one is acute hepatitis. So you can tell that most of the deaths, a large proportion of the deaths in both HCV and HCV are due to these two liver complications, HCC and cirrhosis. And if you want to know the absolute numbers, this table provides the estimated deaths for India and the age standardized death rate, so 7.8 per 100,000 deaths due to liver cirrhosis from hepatitis B alone. So again, you can see that huge numbers there still. And this was a paper that reported the rate of liver complications. So on the left side, you have the incidence rate, so the number of new cases that arose. And on the right side, you have the death rate from both cirrhosis and HCC. So this includes both. The big caveat here is that this data comes from Global Burden of Disease study, which relies heavily on certification of death, which is very, very poor for India. So that's the big caveat. But what this depicts is that there's a percentage change that's happening globally and in India, of course. But for the global point estimate is a reduction in rate of liver complications, whereas for India, what the point estimate indicates is an increase. So from 2007 to 2017, there's the point estimate of the death guess is an increase, but then the confidence level tells us that this is not a very reliable estimate. And the same trend holds for death rate from liver complications as well. So minus 10% reduction globally and 2% increase as per the point estimate. But again, this is not a reliable estimate. And this trend also holds for individually liver cancer as well as liver cirrhosis. Other speakers will talk about this, but just mention here that the global health sector strategy was created by the WHO, and what this calls for is elimination of hepatitis as a public health threat. What this entails and how this will be achieved, what is aimed at is a 65% reduction in deaths from chronic HBV and HCV by 2030, and a 90% reduction in new cases of chronic HBV and HCV by 2030. How this will be done is the only way to go about it is a public health approach. So we need concerted action and leadership from different lines within the medicine and within different professionals acting together, and all of these interventions that form the public health approach have to be implemented in conjunction, and that's probably the only way that we can achieve those targets that are stipulated in the global health strategy. So thank you very much for your attention, and I'll be happy to take any questions that you post in the Q&A section of Zoom. And thank you very much for your attention. And back to you, Dr. Deepshika.
Thank you so much, ma'am. Thank you for enlightening us with the facts and knowledge related to the prevalence of hepatitis B and C virus. So I would like to introduce our next speaker for the day, Dr. Ajit Singh Badoriya, who will be discussing about the transmission and prevention of hepatitis B virus and hepatitis C virus at community level. Dr. Ajit Singh Badoriya is an associate professor in community and family medicine at AIIMS Rishikesh, India. He has done his MBBS from GRMC Gwalior and MD in community medicine from NSC BMC Jabalpur. He has 5 years of experience at the Apex Liver Institute of Country as an epidemiologist and project coordinator to WHO Collaborating Center on Viral Hepatitis. Viral hepatitis is his research area of interest. He has published more than 100 scientific papers, including publications in the Lancet and Lancet Gastrohepatology. He is the recipient of prestigious ICMR Professor B.C. Srivastava Award in 2016, and he is the nodal officer of National Virus Hepatitis Program. He is managing editor for Journal of Medical Evidence, and with WHO HQ's Global Hepatitis team, he has contributed in the Guideline Development Group for HCV self-testing, Guideline Development Group for Hepatitis C, Technical Working Group for HCV self-testing, and developing SOP for enhanced reporting of acute hepatitis cases as scientific committee member from SEER. Over to you, sir.
Thank you so much, Dr. Deepshika, for a kind introduction. And a warm good afternoon to all of you. I'm very grateful to Umesh Kapil sir and Dr. Sareen sir. Both are my mentors and guide. Fortunately, I worked under the guidance of both of these stalwarts. And I'm really thankful to Empathy team at ILBS for providing me this opportunity to contribute in this very useful series of webinar, which is targeting awareness and dissemination of knowledge, building capacity of one and all on hepatitis B and hepatitis C. And as mentioned by Dr. Manya, I think knowledge and awareness will definitely going to play a major role towards elimination targets of viral hepatitis at large, reducing incidence and reducing mortality of these two diseases by 2030. So today I'll be talking about transmission of hepatitis B and C and how we can prevent these transmissions so that we can reduce incidence, and in future we can reduce both morbidity and mortality. So learning objectives, is my slides moving? Can you see this learning objective slide?
So your slides are not moving.
Not moving. Oh, it's okay. So I'll take in this way only.
Yeah, they're moving now.
Yeah. So learning objectives is to make the participants understand about the different modes of transmission of hepatitis B and C. What are the known strategies for prevention of these transmission? Maybe like by going through general universal precautions. Vaccination, a very important strategy for hepatitis B, especially the birth dose to prevent mother-to-child transmission. And then we'll also talk about post-exposure prophylaxis for hepatitis B. So hepatitis viruses, we know there are 5 viruses which cause inflammation in liver. Hepat is liver, itis is inflammation. So inflammation in liver caused by these 5 viruses, A, B, C, D, and E. So A and E, they are both transmitted through fecal-oral transmission, through contaminated food and water. And B, C, D, they are mainly transmitted through parental transmission. So what is parental transmission? Parental transmission is either through bloodborne or sexual or perinatal or through some inapparent horizontal transmissions also. So bloodborne transmission we all know because of our knowledge, awareness about the transmission of HIV virus. It's mainly through multiple blood transfusions. It can be through organ transplant. And there are other nosocomial routes. Nosocomial routes means the routes through which when we are providing care, health care in hospitals, we are transmitting these infections. So it may be due to dialysis in kidney diseases. It may be due to unsafe injection practices, needle stick injuries to healthcare worker, surgeries, dental procedures, organ transplantation. So being in dental profession, this is something which you should all know about, that it can be transmitted through dental procedures also if the equipments, they're not properly sterilized. Then other is sharing of needle among people who inject drug, intravenous drug users. So this is a very important high risk group for hepatitis B, hepatitis C, hepatitis D, and also for HIV. So these people, they're involved in intravenous drug use, and during that practice, they share needles and transmit these infections. So we have to know, we should know that this group should also be targeted to prevent transmission if we want to achieve elimination. Sexual transmission is also common, similar to HIV. Not that common as for HIV, but yes, it's common for hepatitis B and hepatitis C both. Perinatal transmission is mother to child transmission. It is also known as vertical transmission because it's going from mother to child, vertically moving. And this is the most common mode of transmission for hepatitis B. Unsafe injection, unsafe blood, most common mode of transmission for hepatitis C. And vertical transmission, transmitting from an infected mother to a newborn, is the most common mode for hepatitis B transmission. Then fourth one is inapparent horizontal transmission, which occurs among those who are in close contacts, those who live in close contacts like household contacts or children playing with each other, maybe by sharing toothbrush, sharing razors. If there is any exposure to infected blood, then these infections can be transmitted. So this is the important slide to understand what are the different modes of transmission for hepatitis B, C, and D also. Why we don't talk more about D? Because D is defective virus and it always comes with B. So D comes with B as a co-infection, and D comes with B as a super infection. So if we can eliminate B, we can eliminate D also. So that's why we don't talk that much about D. And we are targeting to eliminate B. If we can eliminate B by hepatitis B vaccination, we can eliminate D also along with hepatitis B. So why this mother to child transmission is that important? Why it is that common in India and other developing countries? So there are multiple reasons. First is high birth rates. So we have low institutional deliveries. Still pregnant females, they are getting delivered at home by trained birth attendants. So we have to increase this institutional deliveries. Why? Because if they are coming to an institute, they can be tested for hepatitis B also, and they can be given adequate treatment, like giving birth dose of vaccine at the time, giving hepatitis B immunoglobulin also at the time of birth, so that we can prevent mother to child transmission. So increasing institutional delivery is also a very important preventive strategy. So right now it's low, it's not 100%. Poor antenatal care is also leads to this transmission. Poor birth hygiene, poor coverage of hepatitis B birth dose. We'll talk in detail about hepatitis B birth dose in subsequent slides. And low testing of hepatitis B surface antigen during pregnancy. So now this is mandatory that all pregnant female should get tested for hepatitis B, but still this testing uptake during pregnancy is very low. So if we can know the status of a pregnant female about hepatitis B infection, we can plan to prevent the transmission. So what is the correct strategy to prevent mother-to-child transmission? So first step is screen all ANC for hepatitis B infection. Second is 100% newborn should get hepatitis B birth dose within 24 hours. And third is all those who are born to an infected mother for hepatitis B, they should get hepatitis B immunoglobulin within 48 hours of birth. So if we can follow these three interventions, we can prevent mother-to-child transmission, and in long run, we can prevent or we can eliminate hepatitis B from our country. So targeting specifically prevention of transmission of hepatitis B infection, most important is vaccination. If we can vaccinate everybody, we'll not have people infected, we'll not have transmission of hepatitis B in future. So vaccination includes childhood vaccination, which includes primary 3 doses of vaccination at 6 weeks, 10 weeks, and 14 weeks. This comes as a pentavalent in our universal immunization program. So every child should get these, every infant should get these 3 doses. Then timely birth dose. Timely birth dose means within 24 hours of birth. All newborn should get this timely birth dose. So this is about vaccination in childhood. And then we are also targeting our high risk groups like healthcare workers, like intravenous drug users, commercial sex workers, that they should also be vaccinated so that we can block the transmission of hepatitis B in these specific groups. So how we can be assured about that this vaccine which we have received, now we are protected for hepatitis B transmission. So we go for antibody testing for hepatitis B surface antigen. This is known as anti-HBs titer. So if antibody titer is more than 10, then we are assured that now we are protected. We'll talk more about, we'll know more about vaccination in the subsequent session by Dr. Archana. So other strategies, they are very much similar to HIV. They are very much similar to hepatitis C, that we have to screen blood, we have to give safe blood. We have to give safe injection to all our beneficiaries. Occupational safety is important. If there is a needle stick injury, it should be reported, and a proper post-exposure prophylaxis should be given. Harm reduction interventions, this means that we have to distribute sterile syringes and needles to all those who are involved in intravenous drug use activity. So people who inject drugs, they should get free needles and syringes from NGO or from government, so that we can reduce the harm, we can reduce the chances of needle sharing, and we can reduce the chances of transmission of hepatitis B and hepatitis C also. And then safe sex practices. So for hepatitis B, the important message is that we have a good, effective vaccine. And if we take care of the coverage of this vaccine, we can eliminate hepatitis B in future. Then why we are stressing so much on hepatitis B vaccine coverage? Right now, the coverage is around 87%. The target which we are focusing, or which we are planning to achieve to reduce the incidence by 90% is that this hepatitis B coverage should also be, 3-dose coverage should also be 90%. So you can see for all WHO regions, it is around 80%, plus minus 10 something. So we have to increase it to 90% so that we can be assured that this strategy can help us in preventing hepatitis B transmission in future. So this is the current status of hepatitis B vaccine coverage. How this hepatitis B vaccine coverage impact on hepatitis B infection rate. So in this slide, you can see this is on this axis, it is vaccine coverage. On this y-axis, it is chronic infections. And this is duration from 1990 to 2014. So you can clearly see as the coverage of 3 doses of vaccine, this blue line is increasing. As the coverage of birth dose of hepatitis B vaccine is increasing from 0% to 90% or 80%, there is a significant fall in the total number of chronic infections by hepatitis B, going down from 50 lakh to 5 lakh. So this is the beauty of this hepatitis B vaccine, that if we can have a good coverage, more than 90% coverage, we can pull down the transmission, we can pull down the total number of people who are infected from hepatitis B to a much lower level, so that we can call it as a elimination. So timely birth dose is within 24 hours of birth. Why we want this timely dose? So in this graph, this is very important graph, you should understand it, that on y-axis, we are talking about chronic infection. This side, these are symptomatic infections. Mainly we'll say acute infections. So acute hepatitis, chronic hepatitis. If we can prevent this transmission at birth, we can reduce 90% of the infection converting into chronic hepatitis B. So if the infection occurs early at birth, then the chances of converting it into chronic infection is 90%. So early infection, greater risk of converting into chronic infection. So all hepatitis B infection do not convert into chronic infection. But if hepatitis B infection is occurring early, as we know that most common mode is mother to child transmission. So if it is occurring early at the time of birth, 90% of those infection will convert into chronic infection. Then they may lead into cirrhosis, they may lead into liver cancer also. So if we can give timely birth dose, we can prevent hepatitis B transmission at birth. So that means we will get most effective, or we will get most strong impact of this vaccine if we can prevent this infection early. With time, as the infection occurs in the later part of the life, the chances of converting into chronic infection is low. It is around 3 to 5% if the infection occurs in adulthood. So from 90%, it goes down to 3 to 5% in adulthood. And the chances of acute infection increases, which is milder most of the times and can be controlled. So that's why this timely birth dose is a very important, very effective strategy if we want to eliminate hepatitis B in future. What is the coverage of this hepatitis B birth dose by region currently? So it's as low as only 38%. So we have to increase this 38% to 90% if we want to decrease the incidence of hepatitis B to less than 90% in future, and to achieve the elimination targets, right? So this is very important to understand that birth dose is currently very low, and we have to target this birth dose. We have to train our people. We want our ANMs to understand it, that this birth dose coverage should be increased with time, and it definitely needs education, awareness among community, among healthcare workers. So these webinars will definitely going to help. That if somebody will ask you now, you'll say birth dose is the intervention which we want to increase in our area. So if we talk about post-exposure prophylaxis, if somebody is exposed to hepatitis B infected blood or body fluid, and if the person is unvaccinated, then what we need to do is we have to give a dose of hepatitis B immunoglobulin, and then we'll initiate hepatitis B vaccine series 0, 1, 6. One vaccine right now, then after 1 month, then after 6 months. So that is the 3 doses of hepatitis B vaccine if the person is unvaccinated, after 1 dose of hepatitis B immunoglobulin. If the person is previously vaccinated, but we do not know antibody titer, then get it done. If it is more than 10, no treatment is required, because currently now this hepatitis B exposure will act as a booster for that person. So no treatment is required. If the person's antibody titer is inadequate, it is less than 10, then we have to give 1 dose of immunoglobulin followed by 1 vaccine booster. So these 2 should be given if the antibody titer is inadequate. So this is post-exposure prophylaxis for hepatitis B. Now, how to prevent hepatitis C? For hepatitis C, I told you that unsafe blood and unsafe injection, they are the most common mode of transmission. So to prevent hepatitis C transmission, we have to provide 100% safe blood, 100% safe injections. We have to target harm reduction among our high-risk groups, people who inject drugs, by providing them needles and syringes so that they can stop sharing among themselves and we can block the transmission. Safe sexual practices can also be an important strategy. We do not have a vaccine currently for hepatitis C. So our most important intervention is that we can test and treat these people. So why test and treat? Because we know that for hepatitis C, now we have safe drugs available. They are oral drugs, safe drugs given only for 3 months, and 98% of hepatitis C infection can be cured completely. So we have a cure for hepatitis C. The best approach to prevent transmission is test, start from high risk groups, then we can target hotspots, test everybody. Those who are positive should be treated so that there is nobody in the community who can transmit infection. So for prevention of hepatitis C transmission, safe blood, safe injection, and test and treat policy. So just to summarize, hepatitis B and hepatitis C, they are parentally transmitted. Hepatitis B infection, if occurs early in life, as we know, most commonly by mother to child transmission, then there are 90% chance of converting it into a chronic infection, which has its own consequences like cirrhosis and liver cancer. Vaccination is the most effective preventive strategy for hepatitis B, and we have to target more than 90% coverage for hepatitis B birth dose and also for 3 doses. Birth dose followed by minimum 2 additional doses can provide 90% of prevention from mother to child transmission. So this is a known evidence-based good strategy. Antibody titer, if it is more than 10, then a person is adequately protected. No need for booster in any time in the life. No need for even rechecking antibody titer any time in the life if it comes once more than 10. Safe blood, safe injection practices along with safe sexual practices, they are effective in preventing both hepatitis B, hepatitis C, hepatitis D, and HIV. Test and treat is the best strategy, not only for hepatitis C, but for hepatitis B also, because it can control the disease at least. So if we know who are these people, who are the people who are infected to hepatitis B and hepatitis C, we can treat them and we can educate them so that we can prevent the transmission of these infections to other people who are closer to them. So because hepatitis B and hepatitis C is 95% of the times asymptomatic. So there are people in the community who are infected and they do not know that they are infected and they keep on transmitting this infection in the community. So test and treat is a very important policy. So we'll learn more about our National Viral Hepatitis Control Program, where free treatment, free diagnosis is available. So thank you so much, and I'm happy to take the questions in the panel discussion. Over to you, Dr. Deepshika.
Thank you so much, sir. Thank you for imparting knowledge through your presentation. So the next speaker for today is Dr. Archana Ramalingam. She will be discussing the screening vaccination strategy and health education for HBV, HCV at community level. Dr. Archana Ramalingam, she is working as an assistant professor, epidemiology, Institute of Liver and Biliary Sciences, New Delhi. She's done her MBBS and MD in community medicine from JIPMER, Puducherry. She is the recipient of Professor R.K. Card Best Program in Community Medicine Award in 2014. She has worked in multiple research projects at JIPMER and Maulana Azad Medical College, New Delhi, and at ILBS. She has been a resource person for several workshops on research methodology and basic epidemiology. She is the recipient of IAPSM Ford Foundation Epidemiology Grant and has been awarded Best Oral Papers in several conferences, including IPHA and GARICON. Her areas of interest include non-communicable diseases, which include the non-alcoholic fatty liver disease, metabolic syndromes, viral hepatitis, community-based interventions, health promotion, and medical education. She has published several articles which are of national and international journals of repute. Over to you, ma'am.
Thank you so much, Dr. Deepshika, for that kind introduction. So without taking much of your time, I would directly go ahead and share my screen. So I hope my screen is visible and I'm audible. Could you confirm, please?
Yes, ma'am, you're audible. And you can also see the screen.
Yeah, thank you so much. So good afternoon, everyone. And I'm here to share with you a few views regarding the screening, vaccination, and health education, specifically pertaining to viral hepatitis B and C. I'm sure all the expert speakers before me have oriented you towards why viral hepatitis B and C are important and why public health action is needed for these diseases, and what are the ways by which these diseases are transmitted and how to really prevent them. So I would be focusing on why screening is required, whom should we screen, what are the screening tests that are available, which can be used by most health workers at the periphery, what are the vaccination options for hepatitis B vaccines, and what to do if somebody has missed a vaccine dose, and how are we really faring in the region, that is the Southeast Asian region, as well as in India, regarding the coverage of these vaccines. I'm sure Dr. Ajit has emphasized that vaccination is an important strategy, at least for hepatitis B. And finally, I will touch upon a little bit about health education. So firstly, moving on to screening for hepatitis B and C. Now, from the last lecture, I'm sure all of you have become aware that of the 5 important viral hepatitis, B and C are the 2 things which cause maximum number of cirrhosis, maximum number of hepatocellular carcinoma patients. So B and C are very crucial, and usually they quite a few number of patients develop chronic liver disease because of these viruses. If you look at the WHO document on really diagnosis and the gap in diagnosis, it is clearly visible from this slide that of all the people whom you suspect to have viral hepatitis B and C, the people who are really reached out by the testing services and linkage to care for treatment is really, really low. So one of the major roadblocks or one of the major bottlenecks in the entire cascade of care for viral hepatitis, especially chronic viral hepatitis, is diagnosis. So why there is a problem with diagnosis? Again, because of access to care. So one of the important ways to get around this is making screening tests available, which can be used at peripheral health centers, maybe at PHCs, or maybe even in the future in health wellness centers, etc. So I'm sure Dr. Ajit has spoken to you about what are the key interventions if you focus on which you can achieve elimination by the year 2030. So of that, the first strategy about which we are going to talk about is improving access to diagnosis. If you look at the WHO's global health sector strategy, it says that in order to achieve elimination of viral hepatitis by 2030, you need to at least diagnose 30% of every individual who has got B and C infection by the year 2020, and improve or scale this up to 90% by the year 2030. But where do we really stand as of today? So the latest information that we have is from the Cro Region Report of 2019. We can see that our target is to reach 30% of the individuals and provide them diagnosis by 2020. But for hepatitis B virus, we have reached out and diagnosed only 10.5% of the people in the region. And for C virus, we have reached out and diagnosed even lower number of individuals, only about 6.9%. So we've got a long way to go in terms of diagnosis. When we look at the national program, which I'm sure the subsequent speaker is going to talk to you about, the national program aims to provide these diagnostic services at various levels of care, and they are hoping to provide screening services at the most peripheral of institutions, that is maybe the health wellness center or maybe even the primary health centers. So screening really needs to be offered to any individual who walks into a clinic, maybe a PHC or a health wellness center or a CHC, and requests for testing of viral hepatitis B and C. And it also needs to be provided to all individuals whom the medical officer or the healthcare worker suspects could be a person having high risk for B and C. So any person who walks into a clinic should be provided with testing services if they request for it. And if you are running short on diagnostic services, then preference must be given for the ones who are at high risk. So who are the high risk groups? I'm sure you have picked this up from the previous presentation. For B and C, these are like pregnant mothers, people who use injection drugs, healthcare workers, doctors, nurses, dentists, any other frontline health worker, people who are on hemodialysis, and people who are living with HIV and who are at high risk for HIV. Of course, those are the important subgroups that you need to screen for. With regards to the tests that are available for screening, you have got very good rapid diagnostic test kits that are available. Now, the beauty of these is they can be used by even a peripheral level health worker who is trained to do these tests. They are simple. They give a qualitative result of reactive or non-reactive to the hepatitis B virus or C virus, and they'll offer you quick results. They are also cheap, less than 50 rupees, and simple to use and can be read visually. And they are like a really good test because their sensitivity and specificity is quite high. So they provide you with reliable results as well, so that when you will refer them for confirmation of diagnosis, you do not waste a lot of resources. So what really do these rapid diagnostic test kits test for? So for hepatitis B virus, really you test for the hepatitis B surface antigen. And when you look at C virus, you test for antibodies to hepatitis C virus. My next speaker is an expert virologist, so I'm sure she will be, taking you through the structure of the virus and why these are the options that you're going to use for B and C detection. Recently also, the WHO is looking to improve screening coverage by coming out with an idea of possibility of self-testing. And this could be used as an additional approach to routine testing, which is done by the healthcare worker or by the medical officer. So anyone, once this is rolled out and scaled up, we expect that an individual would do the test at home if he suspects himself to be at high risk. And suppose if the test is non-reactive, then that's okay. But if it is reactive, then he's linked to care, so that he is linked to a service where diagnosis is confirmed and then treatment is offered. So to summarize, one of the key bottlenecks when we look at the cascade of care for viral hepatitis, specifically from the point of view of eliminating this disease by 2030, is diagnosis. Really, there is a huge gap in the diagnosis. As I mentioned, only about 10% of hepatitis B virus patients in the region, and almost less than that, 6% of the C virus patients are reached out by diagnostic services. So one of the ways we can improve this is by offering screening services at the most peripheral level. So we've got very good already existing rapid diagnostic test kits, which are approved. They are cheap, they are easy to use. You can easily train a peripheral health worker. Quick results are available, and they have got very good diagnostic profile. Their sensitivity, specificity is very, very good. So in the future, we are also looking at options where the patient would be able to perform the test himself or herself. And probably the bottleneck there would be linking those patients who test positive to care. So when we move to hepatitis B vaccination, again, coming and having a look at all the key interventions which can help us eliminate these diseases, apart from diagnosis, one of the other key areas is really vaccination. So for hepatitis B, we do have a really good, safe and effective vaccine, which we will look at in more detail in the subsequent slides. So it's a recombinant vaccine and contains a viral protein, which is nothing but hepatitis B surface antigen. And nowadays we use recombinant proteins. Earlier, we were using plasma from persons who are having chronic infection. So what are the common types of hepatitis B vaccine? Now, in the market, the B vaccines are available either as monovalent vaccines, wherein the vaccine will offer protection only against hepatitis B virus, and also as combination vaccines, wherein the vaccine will be given along with other components which protect for several other diseases. So let's see a little bit more about this in detail. So when we look at monovalent options, usually these vaccines are given for adults who want to get vaccinated against viral hepatitis B. So the common one that many of you might have had already is Engerix B that is available in our country. So this is the monovalent option. When we look at combination vaccines, the government of India offers hepatitis B vaccine free of cost to all children. So that combination has got, it comes as a pentavalent vaccine. So that vaccine offers protection against 5 diseases. So in addition to hepatitis B, it also offers protection against diphtheria, tetanus, pertussis, and Haemophilus influenzae B. Whereas if you go to the private sector pediatricians usually give a vaccine which is called as the hexavalent vaccine. So these vaccines, in addition to what I mentioned in the pentavalent vaccine, offer protection against polio also, because they have the injectable polio vaccine component within that vaccine. So if you really look at the options for vaccination, the government offers free vaccines in the form of pentavalent. So in the private sector, you do have combination vaccines against 6 diseases, so that the children need not be, individually vaccinated for each disease. So hexavalent ones are available in the private. And for adults, usually who are looking to get, protection against only hepatitis B, they can go for the monovalent vaccines. So what is the schedule and the dose for hepatitis B vaccine? If you look at newborns and infants, I'm sure you already heard Dr. Ajit speak, and he spoke very clearly that for newborns and infants, you need to give a birth dose. Usually you prefer to give this monovalent vaccine because we want, protection of mother to child transmission. So we give a monovalent hepatitis B vaccine within 24 hours of birth, and then followed by a combination vaccine so that we need not give multiple vaccinations to the newborns. So we give that at 6, 10, and 14 weeks. So the dosage that we usually give is 0.5 ml. So when you look at adult vaccination, the schedule is a slightly different one. So we give vaccination on day 0, then follow it up with one vaccine after 1 month, and then another one after 6 months. So 0, 1, and 6 months is a schedule for adults. And for adults, usually prefer monovalent vaccine, and the dosage is 1 ml. So how good are these vaccines, and how good is the protection against hepatitis B? If you look at the coverage of doses, suppose if an individual is given all the 3 required doses, the protection or the efficacy of the vaccine, as we technically like to call it, is very, very high. So 98 to 100% efficacious if you give all the 3 doses, slightly lower efficacy if you give only 2 doses, whereas taking only 1 dose is not really offering much of protection. So any child or an adult who takes all the 3 primary doses has got a very high chance of getting protected against hepatitis B. So what to do if a child misses the schedule of hepatitis B vaccine? Suppose the child is supposed to take a vaccine at 6 weeks or 10 weeks and has missed that dose. So according to the universal immunization program, if you miss the primary doses, any one of that, so you can be given any time that the mother remembers that the dose has been missed, she can come back and take that dose up to 1 year of age, and then give a gap of 4 weeks for the subsequent doses. However, birth dose, usually we prefer to give it within the first 24 hours. Suppose somebody has missed, then the efficacy becomes low when you move from 24 to 48 hours, 48 to 72 hours, etc. So usually we prefer to give this within 24 hours of birth. So what about an adult who misses the vaccine dose? Suppose he has taken the dose on day 0. He's supposed to come back after 1 month for the next dose, but he misses that one. So if suppose he misses the second one, which should be taken 1 month after the first dose of vaccine, it can be administered as soon as he or she remembers that he has missed a dose. So what about the third dose? Suppose a person has taken on day 0 and he has come correctly after 1 month and has missed coming after 6 months. So that time you can really, as soon as the person remembers, you can offer that dose to him. So sometimes there is a confusion about individuals who do not remember their vaccination history or are not clear whether they have taken 2 doses or 3 doses. The confusion is, can we really give them an extra dose? Yes, you can go ahead and give, because administering extra doses of a monovalent vaccine is seen from studies not to be really harmful. So you can go ahead and give an extra dose whenever the vaccination history is not very clear. So what about vaccinating pregnant women who may be at high risk? Yes, you should vaccinate pregnant and lactating mothers, because pregnancy and lactation are not really contraindications to giving the vaccine for hepatitis B. Especially you should focus on pregnant mothers who may be having more than one sexual partner, or may be getting evaluated and treated for STDs, or maybe an injection drug user, or could have a partner who is hepatitis B surface antigen positive. So these subgroups, you should definitely consider them vaccinating these pregnant mothers if they are not previously vaccinated. How to know if a person is really protected after receiving all the doses? Now, we do anti-HPS titers specifically for healthcare workers to know that if the vaccination has led to immunogenic response. So a level of more than or equal to 10 international units is considered to be protective. So that means that adequate vaccine response is achieved at the end of the full vaccination. And really, studies have shown that if an individual, especially an immunocompetent individual, has at one time point done this test and had an adequate vaccine response, he is protected for a very long time, even for, let's say, about 30 years. So you need not really consider a booster in such individuals. So that is another key take-home message for those of you who are listening. What about the adverse event profile? So most of the adverse events that are associated with hepatitis B vaccines are mild in nature. So usually some patients may complain of pain or, small amount of redness or swelling in the region of where vaccine was administered. Sometimes people may have a slightly increased temperature or maybe a headache, which are all very mild and quite infrequent. You can see that if 100 doses of vaccine are administered, then only about 3 individuals or 4 individuals develop these conditions. However, once in a while, 1 in 1 million doses administered, you do get a case where there is a severe allergic reaction, which we call as anaphylaxis. And this really is the only contraindication for hepatitis B vaccine. So anybody who in a previous dose has had a severe allergic reaction, then that individual should not be given subsequent doses. So again, reminding you about the key interventions, we are talking about hepatitis B vaccination, which I've highlighted in red. And of all the strategies which have been laid down by the global health sector strategy, hepatitis B vaccination is really a key one. So it has got 2 components, the birth dose vaccine and the primary doses taken in 6, 10, and 14 weeks, which we call as the childhood immunization. So let's see how, what are the targets that are laid down by WHO. If we are to reach an elimination of viral hepatitis by 2030, we really need to increase the coverage of these vaccines. So the 3-dose vaccination, which is the childhood vaccination of primary doses, they should be at least minimum 90% by the year 2020. However, if you look at the birth dose coverage, which is very, very poor in most of the countries, we need to reach at least 50% by 2020, and at least 90% by 2030 in order to eliminate viral hepatitis. So how is the coverage in India? If you look at India, we are doing pretty well, I would say, in the 3 doses, that is the primary dose coverage. In the NFHS survey done about, let's say, 6-7 years ago, the coverage was only about 61-62%. Whereas when you look at the latest coverage, which is the latest survey, which was done in 2019, which is the NFHS 5 survey, the coverage is roughly about 84%. So we are very close to the target of 90%, and hopefully in a decade's time, we would get there as well. The other important dose is the timely birth dose. That means within 24 hours, we need to give the birth dose of hepatitis B so that we can prevent mother-to-child transmission. Now, I'm sure Dr. Ajit has explained very nicely to you. I will just repeat that this is a very beautiful graph which talks to you about how many individuals will develop chronic infection depending on the age at which they acquired hepatitis B infection. So suppose an individual acquires the infection at birth, you can look at the x-axis birth, then the individual's chances of getting chronic infection, which is represented here as dotted lines, dotted blue lines, you can see is close to about 90%. That means an individual, if he acquires the infection very early in life, he's got a very high chance of chronic infection. Whereas it becomes much lower even if the individual acquires infection 5 years or older. That is roughly about 10 to 20%. So the take home is we need to prevent early infections, early acquiring of infections for hepatitis B virus, because they have a greater risk of chronic infections in the future. So mother-to-child transmission prevention is the key for hepatitis B virus elimination. If you look at the status globally, there are still several countries. You can see that several countries are here in the orange zone, which indicates that they do not have universal birth dose in their childhood immunization schedules. That means these countries really need to work hard in bringing the birth dose into their scheme of immunization. And you can see several other countries where it is given only to hepatitis B antigen positive mothers, etc. Looking more closely into our region, if you look at the CRO region, the Southeast Asian region where we live, the CRO region, 54% of all the eligible newborns only receive the birth dose of hepatitis B vaccines, almost similar numbers in India, 56%. So if we are to reach 90% by the year 2030, which is very important and key to preventing mother-to-child transmission, preventing those excess cases of chronic infections because of hepatitis B, we really need to motivate the healthcare workers and also bring a lot of individuals to the health institutions for delivery where we can give these birth doses. So one of the key problems why people do not get these birth doses, as you can imagine, is because there could be home deliveries. We have, of course, improved our institutional delivery rate in the recent years, but still storing of vaccinations and availability of an ice-lined refrigerator for maintaining cold chain is really a problem. So the WHO and other organizations have recently come up with another new concept called as control temperature chain, wherein if there is a heat stable vaccine, you can really keep them outside of the traditional cold chain temperatures, even at room temperatures. And you can do this for about 2 to 3 days. So this is a new innovative approach, and guidelines have been released for 4 vaccines as to what should be the roadmap if we are going to use this. And one of the vaccines which is being tried out is hepatitis B vaccine birth dose. So hopefully in the future, we will get enough results to know whether this is an efficacious strategy and whether we should be following this or not. And of course, locally, you can come up with some innovation to bring the individuals into the healthcare system so that they get their birth dose. So to summarize, vaccination is a very important strategy for prevention of viral hepatitis B. It's a very good vaccine, has got very good protective efficacy. More than 95% of the patients are protected. And when you look at the how do you know that there is an adequate protection, you can check for anti-HBs titers, specifically for the healthcare workers. And one of the key interventions for prevention of mother-to-child transmission is the birth dose. And if you give birth dose and then follow it up with 2 additional doses of hepatitis B vaccine, many studies have shown that there is 90% efficacy in prevention of mother-to-child transmission. So before ending, I will just touch upon a little bit about health education. Now, when you want to spread awareness about a disease like viral hepatitis, there could be several strategies. You could use some posters and create awareness. You could generate some buzz around by creating some innovative competitions. You could have brand ambassadors who can, speak. You could have influencers who can mobilize social media. You could run campaigns, and maybe you could call important stakeholders onto a meeting and then discuss about the importance of viral hepatitis. Now, ILBS has employed all of these strategies using their empathy campaign, and they have come out with very good health education posters, which have got key messages related to testing for hepatitis C, related to treatment for hepatitis C, what to do for mother-to-child prevention, birth dose vaccination, and also some general posters to spread awareness about viral hepatitis. They've also time and again created a buzz around viral hepatitis by conducting innovative competitions like the cartoon competition, which they conducted, wherein there were participants from over 40 countries and generated really good informative visuals, which could be used for viral hepatitis awareness. They also ran a campaign called as the Happy School campaign, wherein they brought in all the principals and school teachers of the government schools in Delhi, and then spoke to them over a one-day workshop and really made them aware about the importance of viral hepatitis, what schools can do to prevent transmission of these diseases. And they have a very interesting brand ambassador in the form of Mary Com. She, has done videos which could be informative about viral hepatitis. She constantly tweets, and using her social media presence, she really influences people and spreads awareness about viral hepatitis. We have got excellent faculty videos from Professor Sareen and Professor Ekta. So they give you excellent idea, even for healthcare professionals related to viral hepatitis. And they contain a lot, they have carried out a lot of campaigns in the past in the form of I Pledge campaigns, wherein they have brought various people into the foray of people who will, advocate for viral hepatitis. And of course, they have done key meetings with important parliamentarians. So they have brought parliamentarians on board, policymakers on board, made them get aware about viral hepatitis, and really made them bring viral hepatitis into the public health agenda of the country. So they are active on social media. They've got Twitter, Facebook, YouTube channels, so through which a lot of people access good information about viral hepatitis. And I really thank you and congratulate ILBS for all of their efforts to spread awareness about viral hepatitis. And thanking you. Over to you, Dr. Deepshika. And I think questions would be taken by the faculty during the question and answer sessions. Thank you.
Yes, ma'am. Thank you so much, ma'am, for such an enlightening lecture on the screening, vaccination strategy and health education. So moving on, next we have Dr. Ekta Gupta Mam. She will be covering the needlestick injury and healthcare worker safety for bloodborne viruses. Dr. Ekta Gupta Mam works as a professor and head of clinical virology at Institute of Liver and Biliary Sciences, New Delhi. She's done her MBBS from GSVM Medical College, Kanpur, and MD in microbiology from King George's Medical College, Lucknow. She has received the Best Scientist Award for her outstanding contribution in clinical research by ICMR. She is the technical resource person for developing the National Viral Hepatitis Control Program in India. She has several extramural research grants, both at national and international level, to her credit. She is the nodal officer for WHOCC at the Institute and have more than 100 scientific publications in indexed national and international journals. She is the author of 11 chapters in various books and has major research institutes including hepatitis virus, transplant viruses, and dengue viruses. Over to you, ma'am.
Okay. Can you hear me?
Yes, ma'am, you're audible.
Okay. So very good afternoon. I'm sorry I slightly changed the topic, looking at the audience involved here in the seminar, since you guys are dental students. So I thought, apart from the National Viral Hepatitis Control Program, the very suitable topic would be needle stick injuries and prevention of these needle stick injury for healthcare workers, especially for hepatitis B and C. Can you see my slides as well?
Yes, we can view them, ma'am. Could you also switch them into full screen mode, please?
Yeah, sure. So, very good afternoon, and thank you. I thank Empathy for organizing such suitable seminars. And so the slight topic that I have deviated, especially looking at the audience, which are you dental students, we would be talking about. So here we have talked about hepatitis B and C, what should be done for screening, how the prevention is done. Another important thing is that how do we protect ourselves? Now, everybody has told you that there are 3 important viruses which can be transmitted when we are healthcare workers and we are working on blood products, or especially on patients, oral mucosa, anything. So they are hepatitis B, C, and HIV. So I'll be talking about what are these, and we somewhere down our career get exposed to these injuries very frequent. So very quickly, because I know you all have this curriculum, these topics in your curriculum, but this will be a quick revision. So when we call a needle stick injury, or a percutaneous injury, is that whenever a sharp object, especially a needle, pierces which was in contact with blood or body fluid before the exposure to, and you get exposed to it, then that is a needle stick injury. When it is an unused needle, sharp, which is not being exposed to blood or blood product, and that you have got, then that's simple and accidental sharp injury. It is not as a needle stick injury. It has to be documented. It has to be exposed with blood or body fluids which contain these viruses. So we healthcare workers, we are at very high risk for these bloodborne pathogens, especially surgeons, dentists, yes, of course, nursing staff, technical staff, we people who are working in the lab for their diagnosis, we are every day exposed to a lot of blood and other tissue and body fluids. And so we are always exposed to. So there are three important viruses which are transmitted. These are B, C, and HIV. And there are a lot of needle stick exposures which are occurring. And surgeons, emergency doctors, and lab professionals are at the highest risk of exposure. Now, when we talk about these viruses, now they are present here in the patient blood. So healthcare workers are at risk. So whenever we are working on the patient, we are always at a risk to get. And how do we get? As everybody has said, unsafe injection practices means needle stick injury. Now, but these viruses can be there in the healthcare workers and us also, like doctors, and we can transmit them to patients, especially institute like ours, where you have so much of immunocompromised. So liver disease patients already are immunocompromised. ICU patient become immunocompromised. Post-transplants, they are susceptible. So we can also transmit these infections to the patient. So both ways, we have to be very, very careful whenever we talk about these viruses, because they are in the blood and body fluids. So patients to us and from us to patients also. So the risk, we have talked about B and C, and definitely you can say that why are we creating awareness about B and C is that the risk of transmission for B is so much higher than C, than HIV. So a lot being talked about HIV through the AIDS control program, a lot of IAC material people are talking, but HIV, we take a lot of precautions, but for B and C, we are very careless. If you're working on blood sample, which is containing potentially the virus or from an infected person who is infected with B and C, you have to take universal precautions and you have to be aware that you can be transmitted. So the risk goes 1/3. So the chances if the patient is E antigen positive becomes 20 to 30%. If negative, it is 1 to 6%. For C, it is 0 to 7%, and HIV, you see, it is 0.3 to 0.4. So we remember like 1/3, 130, and 100 times HIV. So HIV is still safer to work on B and C. But the good thing is that for B, you have a very good vaccine. So if you are vaccinated, you are safe. And for C, you have a very good treatment. So this is the silver lining of this cloud, that B, you have a good vaccine, C, you have a very good treatment available. Now, just to know your enemy, so first prevention will come once you understand what is this B and C virus. So hepatitis B virus is a DNA virus, and there are important antigens on its surface. So when we classify virus, we call it a DNA virus or an RNA virus. It is a DNA virus. It contains one important antigen on its surface, which is surface antigen, the spikes you can see which are coming out. And this is a very important marker by which we look for the infection in a patient. We do diagnosis or we do screening. We give a part of this antigen as a recombinant antigen in the vaccine, and antibodies to this antigen only is developed when we vaccinate, which are known as anti-HBs, antibody to S, which is protective. Infection is further confirmed by a test called as HBV DNA test. But since it's a DNA virus, it's quite stable at the room temperature. So it can survive outside the body at least for 7 days, and reports say that up to 4 weeks. So it has to be, but on inside a body fluid or a blood. So organic material, if the virus is there inside in the organic material is present on the surface, can survive for that long also. So one has to be careful about the disinfection protocols. How do we get hepatitis B infection? So mostly, as the previous speakers have said, we get it from mother to child. Now, once you get the infection at very, very young age, that is from at the time of birth, then the chances that the virus will enter your body, will silently enter your liver, remain inside the liver for lifelong, and can cause chronic hepatitis B infection. So this kind of scenario, the chances is 95%. And during this occurrence, the patient is asymptomatic. So patient will not have any sign and symptoms. The virus is there in the blood. Patient may look absolutely healthy, asymptomatic. And if we work on such a patient, we handle the blood of such a patient, we may get very high chances that we'll get exposed to this hepatitis B virus. Once it occurs in adulthood, usually acute jaundice is seen and the virus is cleared from the blood in 90% of cases. Only in less than 5%, some acute liver failure is seen. So the virus is, this infection is a silent, asymptomatic, remains inside the liver for a long time, and there is no sign and symptoms. So the exposure when we are working on the blood or on such a patient is very, very high. Hepatitis C virus, so this completes about hepatitis B virus, so you have to be very careful. Hepatitis C virus is an RNA virus. It's much, much simpler because you have one antigen on its core antigen against which the antibodies are formed. So antibody test to HCV is the test for diagnosis, screening. And then you confirm the infection by looking for a virus, active replicating virus, that is HCV RNA test. Since it's a RNA virus, so it cannot survive for a very long time, but up to 3 weeks on environmental surfaces. Another thing is that since there is no vaccine, so you have to be careful, although the treatment is available by which once infected, you can get rid of the virus very soon. So how do you get hepatitis C? Again, acute infection in which you may have jaundice, clinical sign and symptoms, occurs seen in 20 to 40 and gets resolved. Mostly it is chronic, 60 to 80. So chronic becomes asymptomatic. So again, there'll be no sign and symptoms. Patient's blood will be having this virus, RNA of this virus. So we might get exposed unknowingly if we are not adhering to universal work precautions and biosafety protocols. So we might get exposed to this virus during our procedural work. Now, how HIV B and C are different. Now, HIV, we all know, once infected, goes and enters in your immune cells and it gets integrated into your cells. That is why once you are infected with HIV, you are lifelong infected. By giving the treatment, we only suppress the virus. We are not able to remove it from the body. So this is the status of HIV, and it affects our immune system, so it brings down our immunity also. There is treatment available, but it requires a lifelong suppression and there is no vaccine available. Hepatitis B, like HIV, goes into our body, inside the liver, gets integrated. So as CCC DNA and also here. So this was an old slide, but here also the hepatitis B virus gets integrated into the host cells. So once infected, you are lifelong infected. You can only suppress with the help of antivirals, the viral replication, but you better than HIV, you have a vaccine. So you can prevent this infection. Hepatitis C virus, very much the best virus out of all these three, because it neither goes and gets integrated into the host. So it remains only at the level of the cellular cytoplasm, and you do not have a lifelong reservoir inside the body. So the cure is possible for hepatitis C. So you give a 12-week, 3-month all oral treatment and the virus can be removed. So unlike B and HIV, HCV is curable. So 3 viruses, HIV, B and C. That is why HIV is still considered as dangerous. There is no vaccine, lifelong treatment. Hepatitis B, lifelong treatment, but there is vaccine to prevent. Hepatitis C, no vaccine, but you have a short course treatment and you can totally cure a person who is infected with hepatitis C. Now coming to your preventive measures, when you are working on blood and blood-borne body fluids on patients. So the preventive measures can be divided into 3 parts: pre-exposure, before you are exposed, during the time of work, and post-exposure. So when we are before exposure, how are the preventive measures, which Dr. Ajit has already taken, and vaccination and immunization is an important concept. When you give a vaccine to a person, that procedure is known as vaccination. And when the person develops antibodies to this vaccine, then the word immunization is considered. So a person becomes immune once you show that you have antibody. Now, when you are doing the work, then you have to take universal work precautions. So there are components of universal work precautions: wearing gloves, wearing masks, eye shields, eye covers, safe disposal of sharps, never recapping the needles, all those procedures, careful sterilization, disinfection, all those components have to be taken care irrespective of the status of the patient. And that is why we call it as universal work. We do not test for BC and HIV in a patient. Whenever we work, we adhere to these practices. That is another way to prevent exposure to these viruses. Now, in case, unfortunately, you are exposed, then how do you manage and monitor and give some drugs? That is known as post-exposure prophylaxis. That is also a preventive measure. I'll be talking about this post-exposure prophylaxis. Hepatitis B vaccination, the previous speakers have already covered. This is just a data to show that although we are talking about it, what is the status of this vaccination in healthcare workers? Even we did a study. Though the free vaccination and mandatory vaccination policy is there in our institute, 85% complete vaccination history we get, still 15% come up with no history of vaccination. So, and other institutes are showing a varied data of 50, 40%. So this means even healthcare workers, we need so much of awareness that we have to go and complete our vaccination schedules or get vaccinated if we have not taken the hepatitis B vaccination. This Dr. Archana and Dr. Ajit both have covered, so I'm not going to go into it. Just quick word that anti-HBs titer is the titer by which you measure the response to the vaccine. If a person is absolutely healthy, has got no risk, means is not a healthcare worker, totally immunocompetent, there is no need to do this anti-HBs titer. But yes, in healthcare workers, we normally check because we want to know they are responders or non-responders. And this is usually done 1 to 2 months after giving the vaccine dose. Now, anti-HBs will tell you whether you are able to mount immunity against the antigen that is given to you, and a level of more than 10 is considered protective, and we call the person immunized. So you don't have to repeat it again and again. You just, as a healthcare worker, we require one documented proof that we have received all 3 doses and has once achieved this titer of more than equal to 10. So you don't have to get it done every day, every year, because the anti-HBs levels, they wane, they go down. So if you are vaccinated, let's say 3 years back, so your levels would not be the same as 2 months post-vaccination. But only thing is that if you know and you have a documented proof that we have received 3 full doses, and once we have shown that my bodies has shown an adequate response, then it is a good enough way to evaluate healthcare workers. This is a post-exposure prophylaxis, a pre-exposure prophylaxis we do for the people who join our institute. Each institute, because it is not mandatory by the government of India. So we really do not make the policy that once a person comes and joins our academic institute, what do we do? What we do in ILBS is at the time of joining only, we'll ask the complete details, whether you have received 3 doses, not remember, do not remember, and also look for an anti-HPS titer. Now, if the person's healthcare worker who has received all the 3 doses, complete 3-dose schedule, if shows more than 10, it's adequate, nothing to be done. If it is less than 10, we give 1 booster dose and then try to see the response. If still the healthcare worker shows less than 10 after 2 months of the booster dose, we give 2 more doses of hepatitis B so that we complete the vaccination. Again, the healthcare workers cannot develop an adequate immune response, then we declare that healthcare worker as a non-responder. Now, there are the institutes, you can have several ways of handling the non-responders, but such non-responders should be first evaluated for hepatitis B, whether they are infected, not infected. They can be given alternate higher dose or some booster enhancement for developing an anti-HPS, but these need institutional policies, or else you need to be educating such healthcare workers. The C you have not developed and you're going to work in our place, chances that you may have B infection. So please adhere to universal precautions, wear 2 gloves, do not put that person into a high risk patient's care, so that the person, you know that as a person is non-responder. But mind it, non-responders are very, very less. In our my 15 years of career in this institute, we have only seen 1 or 2 non-responders in healthcare workers. And so mostly people respond very well to this. So there is a need for institutional policies for healthcare workers on their vaccination, that what is the vaccination status of people who are working in our place. Now let's come to what if the needle stick injury occurs. So if the needle stick injury occurs, the risk of acquiring the infection depends upon what is the type of body fluids you were exposed to. The quantity, if it was blood from a B infected or C infected or HIV infected in large amount, what was the type of needle, big gauge needle, deep cut, all these things need to be, the information need to be made available, that influence that you will have a risk of having an infection or not. What are the practices? So mostly in our setting, the recapping of needle is one of the most dangerous practice that we adhere to. And you should have needle destroyers, you should have self-destructive needles, you should have should be available and should never be able to recap the needles. And then you should not disposing them properly in the puncture resistant sharp containers as per the biomedical waste guidelines. And you do not have good waste management guidelines available in your institutes. So I'll just quickly, I think all of you know, and if you don't know, then you must make these steps and should display them at your place of work so that people know what to do. So first is the step is management of the first aid to be given. I'll come to these do's and don'ts. So I'll stress. So first thing is that in case the exposure occurred, you have got an exposure from the infected sharp or a needle, and that's a bigger one, it is pierced, and you had a splash on your eyes or something. So first thing is do not panic. And if it is a prick on your hand or something, please do not put that infected or that blood-stinged finger into your mouth, because again, you will allow the virus to enter through mucosa now. So that habit of just putting your finger into your mouth should not be done. Never squeeze, because by squeezing, we further, damage the superficial capillaries, and we allow the virus, we make the virus to pave more into our blood. So never squeeze, just put into the running tap water, let it, the blood and everything wash under the running water. And if it is your eyes, then just rinse it with water. And mild soap should be applied, not very harsh antiseptic or detergent, because you don't want further injury of your capillaries or subcapillaries. and immediately contact a person who is expert in handling. So this is the categories of exposure: mild, moderate, and severe. So you need to record the information once a needlestick injury, and then first counsel, because usually when the exposure occurs from a B infected, especially the HIV infected or C infected, the healthcare worker is very, very panicked. So you need to counsel that nothing. So as I told you, if you are vaccinated for B, no, nothing to worry. For HIV, yes, immediate PEP to be given, nothing to worry. For HCV, again, there is a drug available in case you get infection. Chances of getting an infection is very, very less, so nothing to worry. So all the three virus, nothing to worry. So this kind of counseling needs to be given by a senior to a person who suddenly gets exposed. What we do, we test for all these markers in both the source, we call source the patient or whatever from wherever the injury has taken place, and exposed is the healthcare personnel or the worker to whom that injury has occurred. So you check for BC and HIV by these markers. Now, in case the person source is HIV positive, the patient is HIV positive, then remember 2 hours is the golden rule. Then the post-exposure treatment, which is tenofovir, which is a combination of drug, which is available, freely available. If your center does not have, you can procure from any ART center, you can buy from your pharmacy, and plus keep it to a resource person. That has to be started within 2 hours, as irrespective of the exposure status, you just have to start. So if you see that the exposure has occurred from HIV, this drug to be given, and it should be given for 4 weeks, so that there is no chance of entering of the HIV. This is totally as per the NACO guidelines. It's given there. Now, in case of the source, means the from where you have got, is a B infected person. Again, the golden hours are 48 hours of exposure. So in case you have to give immunoglobulin or a dose or vaccination dose, then it should be all done within 48 hours. So 2 hours for HIV and 48 hours for HBV. So whenever you have an exposure, why I'm stressing on these hours is that please, these are crucial timing. Do not hide, sit, go back home, be scared. Go to a person, inform that I got exposed. I think I had a splash, I had a prick or something, so that the management can start within these golden hours and the damage control can be done. This is the way we do for B, because you have to have an evaluation of the exposed. Now, see, nothing to be done if the person, means the exposed person or the healthcare worker, is a documented responder after complete series of vaccination. So if you have 3 doses of hepatitis B and you have demonstrated a more than 10 anti-HPS titer, means I am a responder, I have got vaccination, then even if I am exposed to the blood from a hepatitis B infected, no action needs to be taken. Now, in case you are a non-responder, even if after you are declared non-responder, then immunoglobulin is the only recourse. We give hepatitis B immunoglobulin 2 doses to be given immediately within 48 hours. Now, if you do not know the response, in that case, and you have a big exposure and you have shown less than 10 titer once, so then 1 immunoglobulin dose, and we start the revaccination series for the healthcare workers. But in case you after your response is more than 10, then no action needs to be given. Yes, if you do not know you're vaccinated and completely vaccinate anything, then you have to start the complete course, and you can also give 1 immunoglobulin if the exposure is there from a positive person. So I hope it is clear. So everything comes down to your hepatitis B vaccination and your response status to that. So if you're not vaccinated or you've never gone and get an anti-HPS titer done and you're working on patients in blood and body fluids, please go and get your anti-HPS titer done. And if your institute has not made a policy, please go ahead and make a policy for the same. What needs to be done for C? So there is no post-exposure prophylaxis for C. We only wait and watch. So when a person is exposed to C, we get the source status done. We also get a baseline healthcare worker status done, but we wait for the healthcare person to get converted into hepatitis C infection. And if he becomes an hepatitis C infected person, then we give the complete treatment, which is 12-week treatment, and 95 to 96% chances that the person is able to clear. That becomes an acute HCV infection for that healthcare worker. So this is the protocol. Means in case of you're exposed to hepatitis C, do not panic, just wait and watch for 1 month, get your anti-HCV or RNA test. If you have to have an infection, it will be, you will become positive within 3 weeks time. So once you become positive, then we will. So nothing need to be done. Only thing is that we keep on doing these tests on the healthcare worker, like HCV RNA 3 weeks, and then antibody test at 1 month and 6 months, so that we see that the patient kahin se usko infection ho to nahi gaya. That's the only thing we do for HCV. No post-exposure prophylaxis. Matlab, without seeing that the healthcare worker has become infected, we do not give blindly any antiviral treatment like we give in HIV. For HCV, it is very, very clear. And chances that it is very, very, very less for a person to acquire HCV infection from these needlestick injury. So most of the time, you just have to allay the anxiety of your healthcare. Usually follow-up testing once you are exposed to these bloodborne viruses is for 6 months. We do at 6 weeks, 12 weeks, and 6 months. And we always tell them to use precautions. And in case you are developing any clinical symptoms, you may come for medical evaluation, and you keep on counseling the healthcare workers. The documentation is very, very important. You have to write down everything in case a person is exposed to these needlestick. So the training and IEC active a very important role in safety. Now, as you can see, that if you give adequate training, how to work, how to dispose of sharps, how to handle needles, do not recap, use needle destroyer. So the 34% reduction is there in needlestick injury in a healthcare setting as per this paper. If you're using safety engineered devices like with recapping, automatic destroying, 50% chances are there. And if you combine all these things, then 70% chance you're going to prevent these needlestick injuries in your place. So what are these safety engineered devices? These safety engineered devices are safe needles and syringes which come with a protective shield, or they are self-destroyable, like, or the recap, you don't have to recap, it is automatically capped with one hand. So this is the way, if you start buying these kind of needles, when you're working on highly infected patients who are HIV, B and C, then you must give such kind of needles for your healthcare workers to work on. Also keep on giving them training, advising, make a very good needlestick injury protocol in your place. So 70% chances that you can prevent these unsafe injections. We at ILBS has got a website. You can log on to this, where we keep on uploading some videos and trainings, and you can contact us through this website. This is an initiative by ILBS there, where we try to give education to needlestick injury, especially for B and C post-exposure prophylaxis. Now, the last part of my talk, that what if the healthcare worker is infected, and all about this. So we do not discriminate. So if a healthcare worker at the time of joining your institution turns out to be B, C, HIV positive, although we do not have Indian guidelines and law in place, but whatever occupational guidelines CDC and UK practices, you do not discriminate. You cannot tell. Only thing you need is regular follow-up and very careful advice, and the privileges where that person can be allowed to work. So as per these guidelines, for HIV, if the person has got very high viral load, you can prevent them from working in exposure-prone procedures. What are exposure-prone procedures? Like when you're doing something really intravenous, you're putting catheterization, blood to blood, or where the chances of exposure becomes very, very high to the patient here. So in that case, you may restrict if your healthcare worker is HIV positive and has a high viral load, you may restrict. Now, cutoff for B and C viral load is that if the healthcare worker should always have less than 2,000 or 1,000 as per these guidelines, the viral load, and should never be E antigen positive. And that case, there is no restriction for any healthcare worker in the work, or otherwise you just prevent them from doing work on exposure-prone procedures. So again, I want to say there are no guidelines in India, and it is also not mandatory to test the healthcare workers for B and C infection in your institute, but you can make your own guidelines. Right now, we are working at the national level viral hepatitis program to have these guidelines implemented at the government level so that each institute works, whether private, government, we have uniform guidelines, what to be done for healthcare workers who are infected, or what kind of policy should be there. We do not have any such guidelines. So I end my talk by telling that we have to be aware about the possible risk of acquiring these bloodborne viral infections. Prevention is always better. So universal work precautions, hepatitis B vaccination is a very, very important method by which you can protect ourselves from these deadly viruses. But even if you get exposed, please do not panic. You have stepwise management available, and there is a need for formation of the national guidelines for healthcare workers' safety in case the healthcare worker is infected, and then how to manage and where to put that healthcare worker. Thank you. I thank you all.
Thank you so much, ma'am, for such an informative presentation. Next, we move on to the next lecture. I would like to invite Dr. Arundeep Singh, sir, Principal, Manav Rachana Dental College. He will be discussing about the hepatitis prevention and management in dental clinics. Dr. Arundeep Singh, sir, he has done his MDS from Nair Hospital and Dental College in Mumbai. He has over 22 years of teaching experience, which includes 3 years at Maulana Azad Institute of Dental Sciences. He has lectured at various IDA meets and conducted various CD programs at colleges, with numerous papers presented at national and international conferences. He has been actively involved in designing and conducting diploma courses at IGNOU, as well as authored chapters in textbooks of conservative and endodontics and dental materials. He is a review of many specialty journals, including conservative dentistry, and he has been an examiner at various universities for both undergraduate and postgraduate exams. At present, sir is the Joint Secretary at Indian Endodontic Society and in the Executive Committee of Indian Dental Association, West Delhi. Over to you, sir.
Thank you, Deepshika. Can I share my screen?
Yes, sir, please go ahead. You may put your presentation and share screen. Yeah, we can view it now. Could you kindly switch it on to the full screen mode as well?
Yeah.
Thank you.
Okay. First of all, it's really an honor to be presenting among such luminaries from all over India who are so actively involved in management and spreading awareness about hepatitis. And I'm doing my two-bit, in the sense, like I said during the inaugural address, that I got exposure to empathy nearly 2 years back. And there, one pledge that we took was to at least, inform 10 people about the program. And I am taking this opportunity to spread it amongst my students and with nearly 150 people who are already attending. So maybe 15 times of my pledge I'm trying to redeem through this talk. Now, the advantage of speaking nearly in the end is, yes, you get less attention from the participants, but more importantly, whatever you were planning to talk has already been spoken about in some form or the other. So what I'm going to present today briefly is the dentist perspective in control and prevention and management of hepatitis. And I think that is of prime importance to the students here. I remember my time when I studied hepatitis in my microbiology so many years back. We were taught about Australia antigen, which was probably the first biomarker which was discovered by Bloomberg, and subsequently it was identified to be a marker for hepatitis B. So as a healthcare worker, what we have to see is that we have to talk about universal protection. Now, Professor Gupta had just spoken about it. I think that is what, you have to treat each patient as if he is infected. Now, what I've seen is that when HIV came and the dental profession really changed, we were, before that, we were not very careful. And since HIV came and there was no cure, and you knew that as a dentist, you're getting exposed to blood and saliva, and there's a chance of transmission. So we started following precautions like wearing gloves. Before that, I'm talking about many, many years back, dentists never used to be wearing gloves. So since HIV came, that awareness was created. And now with this pandemic, we have more awareness about transfer of infection through aerosols, and we are all, into PPEs. And it is the need of the hour to protect ourselves, to protect our patients. Hepatitis, it is said that it is something that can survive on the environmental surfaces or on hard surface for nearly up to a week. While HIV virus is very fragile, gets destroyed very easily, but hepatitis virus can survive for a week. So we as healthcare professionals have to be very, very careful, and we have to protect ourselves, protect our patients from the spread of the virus. So these are the different kind of viruses already been spoken to by the various speakers before me, Dr. Ajit, Dr. Gupta, ABCD, Dr. Sareen in his very informative videos spoke about all those 5 viruses, 5 types of hepatitis that are, you can count on your finger. So now, what are the vectors of infection to which a dentist is exposed? As a dentist, I am exposed to blood. Studies done by various dental schools have shown that endodontists, that is root canal specialists, then periodontists and nodal surgeons are the most exposed to blood. So what we have seen is that the virus titer in blood is a maximum. We say, okay, nasopharyngeal secretions. Now I said, like I said, after the pandemic, we are looking at aerosols and people sneezing, and saliva was of course always a threat. So, but what has been determined is that the amount of virus load in blood is the maximum compared to all other vectors that we see. So we have to be very careful, even though we might find hepatitis surface antigen in saliva in higher numbers, but it is nearly 1,000 times more than the actual load. So what we have to be as dentists to be careful about is the presence of the virus in blood. Now the exposure to dentist is multifactorial. You have exposure through needlestick injury, which has been really well covered by Dr. Gupta just now. And we have to be careful. Now, we have to train ourselves that we do not injure ourselves. No, we as dentists are maybe casuals at time, and we have to ensure that we do not injure ourselves with needlestick. That's the most common cause of spread of hepatitis amongst dental professionals. And it can be through needlestick injury. It could be through some contact with of our dermatitis of our skin through potentially infectious blood tissues and other. And there are 3 ways of exposure. Now, there is one patient to patient exposure. Now, that is if you don't take care of maintaining universal precautions, then we can transfer the disease from one patient to another. Then, of course, there is from patient to provider. So the patient can, if we get pierced by blood infected by a patient who is hepatitis positive, then there's a chance that the provider, that is me as a dentist, can get hepatitis. And of course, the third is from provider to patient, which is again a rarity with the kind of infection control and kind of awareness that we have amongst health professionals. But these are the main modalities of transfer. So now, what are the guidelines? Now let's come to the brass tack. Now, what are the guidelines for treating hepatitis patients? So we as dentists, if we know that somebody is into an active hepatitis state, then we should only give emergency treatment. This is the same protocol we followed for COVID also. Only emergency care was given to somebody who is positive. So we have to be sure that we do not do routine procedures for somebody who has come with known case of hepatitis. Now, how do we find out? That's where the importance of obtaining proper history from the physician or from the patient. Check for history of fever, check what kind of environment the patient is coming from, check from what is the background, what is the area, if there's a proponents of spread of hepatitis in that area. So you need to be aware, and a proper history taking is of prime importance. And for recovered patients also, for somebody who says, okay, he's got recovered. So we have to be aware that this patient can transfer the disease for nearly 3 months after being infected by hepatitis. We have to be careful about that. So again, a good proper history taking is of prime importance for dentistry per se, and also for any kind of healthcare personnel. Now, somebody who is HBs, AG positive, that means surface antigen positive, is probably infected. So we have to ensure that only emergency treatment done. And somebody who has antibodies. Now, somebody who's got himself vaccinated also would have antibodies to hepatitis B surface antigen and can be treated. And patients who are hepatitis B surface antigen negative can be again treated very routinely. Now, what all can you do? What are the precautions? Say if you have to treat a patient who is active, who is a carrier, and he's come to your clinic. So what are the precautions that we need to follow? So first is, of course, try to find out the status. Second is you should measure the prothrombin time. Now they say that hepatitis also alters coagulation. So whenever we are doing a surgery, we are planning to do an extraction, or you're trying to do, say, a periodontal surgery or an impaction, we should ensure that we check for prothrombin time. And PPEs have now become a norm in all dental clinics. We should treat, like I said, every patient as a potential infectious patient. So you should use full barrier techniques. You should use masks, gloves, glasses, eye shield, disposable gloves, the works. So you have to protect yourself, and you have to protect the patient after the patient that you're treating. And once the treatment is over, we have to ensure that all the disposable items should be put in disposable covers, and we should label them as infective and dispose them as a biohazardous, and we should dispose them through our agents for proper disposal after the treatment is completed. Again, like I said, we are now become conscious about presence of aerosols. So we have to ensure that we do not do any kind of ultrasonic. Ultrasonic creates a lot of aerosol in the clinic. Now we are in a closed environment in the clinic, and if we use ultrasonic, which will give me aerosol mixed of blood as well as saliva and normal water. So we have to ensure that we do not use ultrasonic instrumentation, and we should try and minimize use of high-speed handpieces, because we should try and use micromotor. Again, that is because they create a lot of aerosol. Another new thing that we started following, though it was there in the books for such a long time, that we have to do a pre-treatment rinse with chlorhexidine or with povidone iodine for 30 seconds. Tell the patient to swish the mouth with pre-rinse of chlorhexidine, gluconate, or povidone iodine for 30 seconds, and that significantly decreases the viral load in the oral cavity. So once the procedure is complete, we have all those instruments that we have to sterilize. We should scrub them properly. We should pack them and sterilize them again. And we should ensure that there's no blood and there's, it is ultrasonically treated first, and then the proper protocol of sterilization needs to be followed. And all working surfaces, environmental surfaces should be wiped with 2% activated glutaraldehyde. So what do you do in case of post-exposure prophylaxis? Again, something that has been very well handled by Professor Gupta in much detail. I also got few tips from that. Yes, you have to, wherever there's a site of exposure, of injury, you should run it. We should promote active bleeding in a way that the blood can flow properly, and put it under running water. Another thing that is of importance is we need to document our injury. Then we need to evaluate what kind of exposure we've had, what is the source of exposure, what is the chances of that patient having hepatitis. All these needs to be evaluated, and we should not panic. Like Professor Gupta was saying, we have not panic, and we know there's treatment available and we'll be able to manage. So we have to have control monitoring of any of the medical staff which has been exposed to hepatitis. So you can do testing for hepatitis B virus, mandatory counseling is there. Then we should look for antibodies. Again, it was very well described in the previous presentation that we should test for antibodies 1-2 months after the last dose of vaccine. So all these are the things that we have to ensure so that we can protect ourselves. Now, what is the prevention in dental setting? So again, Dr. Gupta has covered that we have to ensure that we use one hand scoop technique. We don't use both hands to scoop our syringes. We should not try to bend or break needles before disposal. We should try not to pass a syringe with unsheathed needle. All that, especially with our dental burrs. Again, dental burrs can also kind of create some kind of injury. So we should ensure that when we are giving our hand pieces for sterilization, we remove the dental burrs and then give for sterilization and disinfection. Then you should place all disposable syringes, needles, blades in proper puncture-resistant containers, so that they do not cause further injury. And instead of when you're passing any sharp, if you can loudly say, okay, now you're beware that I'm going to pass this to my assistant or to my other doctor. So that is going to be of lot of use for preventing the spread of hepatitis. Now, what are the immunization for healthcare worker? Again, very well covered already. We need 3 standard doses of 0, 1, and 6. We at our end, the first speaker, I think Dr. Mania was speaking about how the program got derailed during the hepatitis, during the pandemic. In fact, my college also, we had 2 doses and the 3rd dose was not given because the pandemic started. And now we know that, okay, if we have 2 doses, most of our students at that time and faculty had 2 doses. So I'm sure we are at least 90% protected, and we can work around for having the 3rd dose. So now in a dental setting, what do you do when the patient enters? So first the patient is entering, like I said, there's importance to take a good medical history, and all patients, universal precautions that Professor Gupta was talking about, all patients have to be treated as if they are potentially infectious. So that means you should follow universal protection to ensure that you do not transfer the disease from one patient to another patient. So the following patients have been history taking will tell us somebody with leprosy, lymphoma, patients with immunosuppressive drugs have been shown to have higher carrier rates. So we have to be aware and conscious. Now, this is a summary of standard precautions to prevent transmission in dental setting or in any kind of a setting where a healthcare provider or a dentist has exposure to blood and saliva and other fluids. So hand hygiene, we should ensure that we do proper cleaning. We have proper cleaning of our hands before gowning up and before scrub up. We should have proper hand hygiene. Then, like I said, personal protective equipment, these are again becoming the norm. And we should wear proper gloves. We should have eye protection. We should wear a gown, a disposable gown. Nowadays, the patients are also aware. You know, with this pandemic really affecting everyone, patients are also looking out that how a dentist is trying to protect him or her. So it is very important for our practice to follow all the protocol, and the awareness has significantly increased in the minds of the patient. And we should also, discard soiled patient care equipment, and we should handle it in a manner that the microorganisms are not transferred to the others and not transferred to the environment. We should wear gloves to handle if these patient care equipment are visibly contaminated. Then we have to ensure our environment. Nowadays, we're talking about how the clinic operatory you should have a continuous flow of air. So, there should be at least 6 air changes in an hour in any closed environment, so that there is no accumulation of virus in a closed space. So again, all these things we as dentists have to really start thinking about, start investing for our sakes, for our family's sakes, and for the sake of our patients. Then these other points like handling of needles and injection safety have been very well handled by the previous speakers. So I'll go on to the next slide. That we have to, like I said, we have to manage the sharp waste well. We have to not use 2 hands for recapping the needle. As you see here, if you use 2 hands, there's a good chance that you will pierce yourself and cause a percutaneous injury. And now this is the one spook technique, which ma'am has also spoken about. I have a small video on that. Let's see if we can play that. Yeah. So management of sharps, they have to be put in proper tamper-proof containers so that they do not cause injury to other people. So that is primarily what we as dentists should be doing. So it's a very simple that we have as a summing up of my today's presentation is that in our clinical setting, we have to train our assistants to be very cautious. We have to ensure that, between patients, the seats are properly wiped, the dental chair is properly wiped, and there's no visible blood or saliva, because, we as dentists have this habit of patients waiting and you want to take the new patient immediately. So all these should be part of our normal behavior and normal infection control protocol. We have to obviously use disposable needles. We should sterilize instruments. We have learned about how the sharps have to be disposed, then importance of taking a thorough medical history, using of PPE, and the most important carry-home message for about today's awareness is getting yourself vaccinated. The start would be probably when you're employing a new person also, especially in a healthcare environment. Then we should ensure that that person, like ma'am said, that we would fill up a form and see what the status is, and ensure that the person is pre-vaccinated. So if the person is vaccinated, then we are doing our bit in kind of stopping the propagation of such a dangerous disease. And as a healthcare institution, we should have proper processes for instrument reprocessing, how the sterilization has to be done, then how the cleaning between patients has to be done, and how do we manage when the injuries are there. So these are, I think, the relevant points to what a dentist should do to protect themselves, their patients, their practice, their family from hepatitis. So thank you again for the opportunity. And I'm sure today's talk, though we've really shot beyond time, has been very beneficial for all our participants. Thank you very much.
Thank you so much, sir, for the enlightening lecture. So now we move on to the oath ceremony. I will hand over the mic to Dr. Namrata to carry forward.
Thank you so much, Dr. Deepshika. I pledge oath ceremony is a symbolic gesture for requesting you all to stand with our fight against hepatitis B and C and show solidarity and support. For this, may I please request all the panelists to kindly switch on their video cameras and also unmute yourselves. Please raise your right hand and repeat after me. I pledge that I will try to keep my liver healthy.
I pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you all. Over to you, Dr. Deepshika.
Thank you, ma'am. So next we have the question answer round. We have an open house discussion. So we'll take the questions. So since there are no questions in the chat box written, so we'll move forward to the vote of thanks. So I request Dr. Ruchi Pandey, Professor, Department of Periodontology, Manav Rachna Dental College, to deliver the vote of thanks. Thank you, Dr. Deepshika. On behalf of Department of Periodontology, I thank all the esteemed guest speakers for sharing their valuable knowledge. Team of Institute of Liver and Biliary Sciences, Principal and Vice Principal, Sir, MRDC, and all the participants for joining and making this program a grand success. I will like to end the program and will request all the participants and guests to kindly fill up the post-webinar survey as well, so that we can generate the e-certificates. Thank you.
Thank you all for joining us today. And thank you so much for your patient listening. Kindly do take the time to fill in the post-webinar survey and be patient and bear with us, as the certificates would take about 3 days time to reach you all. Thank you so much. Dr. Pooja, we've wrapped up from here. We may sign out.
Okay, thank you, madam, for everything.
Thank you so much for your support. You've been great as a co-host, and we'll see you soon on 28th.
Okay, ma'am. Thank you.
Thank you so much, Dr. Arundeep, for joining us.